Good morning, everyone. Thank you for coming to the New Hampshire Insurance Department's public informational hearing on network adequacy. My name is Richard McCaffrey. I am the department's Compliance and Enforcement Counsel, but I stand before you this morning much more in the role of a housekeeper, because I have been asked to point out certain important but rather ministerial matters. First, in the event of an emergency, please note that the emergency exits are located at the back of the room and to the side of the room. Deb O'Loughlin showed me this motion. I will warn you that should you choose to use the exit to my left, you will be greeted by a pile of chairs and a darkened door, so good luck to you. The restrooms, as you may have noticed on your way in, are out the doors to the left, and you'll see them. There is a cafeteria that is located downstairs in the building. And last, the electronic devices, if you have them, please silence them now. There are located outside the doors very helpful, friendly insurance department staff who can assist you with any questions, locating the cafeteria, locating the restrooms, or other needs that you may have, so please consult them. With that, I would turn the hearing over to the Insurance Department's Commissioner, the Honorable Roger A. Savini.
Thank you very much, Dick. And again, welcome everybody to this public hearing this morning. The public hearing, as you certainly all know, is on the limited networks and the state standards for network adequacy for not only Anthem and the plan that they have on the exchange, but for all insurance carriers doing business here in the state of New Hampshire. As Dick said, I'm Roger Savini. I'm the Insurance Commissioner, and I have with me today the staff that works primarily on health insurance matters that are going to take part in the presentation this morning. There's a slide that shows the names of each of the staff and what their positions are, and I'm not sure who's running the slideshow. Nobody. Many of you are here on behalf of Frisbee Memorial Hospital. Others of you are here because you have interest in what's going on in the state of New Hampshire with regard to networks, network adequacy, and Anthem and their plan. Others of you are here because you've either purchased or are thinking of purchasing a plan on the exchange. And if you do so, you've seen that your medical provider is not a part of the network. I understand all of these things. I especially understand the last one. That's happened to me on a number of occasions. So I know that it's not easy when you have to change providers from personal experience. Again, I've scheduled this public hearing not only to review the standards that are used, but to get public input on what changes we should consider to these standards. It's what we intend on doing, what we at the department intend on doing is convening a working group of stakeholders, much as was done in 2001, and what Deputy Commissioner Feldwebel is going to explain to you, to look at the rules and see what changes should be made and propose those changes after considerable input to the Legislative Rules Committee for consideration. Again, as I said, the purpose of the hearing is to get your input, get your personal experience, find out what it is you would like to see with regard to networks in the future, and help us work with the legislature to accomplish the ends that you and we believe should be accomplished. For today's hearing, again, as I said, we're going to start with a presentation from the Insurance Department. Next, we're going to ask for the public to provide us with their comments. What I've asked is that if you intend to speak, you limit what you say to 5 minutes, and that in advance of that, you've already completed a card indicating that you would like to speak and who you are and who you represent. After the public testimony, we're going to take questions and answers. In order that we get through as many of the questions as we possibly can, I've asked that these questions be written down and handed in so that we can go through them systematically and make sure that we answer as many of the questions as we possibly can. The public hearing is then going to be closed with Frisbee making its presentation. With that, what I'd like to do is to ask Alex Feldwebel, our deputy, to give you a brief history of the New Hampshire's Managed Care Law and Network Adequacy Regulation. Alex?
Thank you, Commissioner. Our Network Adequacy Law went into effect in 1988 with the Managed Care Law. HMOs came into the state in the early 1990s, and with that came the issue of limited networks, because, as you know, as HMOs were first designed, they involved limiting care to the network of participating providers. So New Hampshire sort of went through the experience once of dealing with limited networks. First came into the state, and the response was to pass a managed care law that set standards for managed care. So one part of that managed care law was a very basic standard for adequacy of networks, which is that every health carrier has to have a network of healthcare providers that's sufficient in type of providers and geographic location and number of providers to ensure that all services to covered persons are accessible without unreasonable delay. So that's the basic standard that's in the law. The law then required the commissioner to develop a regulation that fleshes out that basic standard. 2001, we had the obligation to develop a regulation for network adequacy, and the way we did it was to convene a working group of stakeholders. So we had providers of various sorts: hospitals, community health clinics, nurses, physicians, mental health providers. We had all the major health carriers, and we had a consumer organization representing consumers. And we worked through the details of the network adequacy standard. We looked at what other states had developed, and we came up with the regulation that we have today. Okay, next slide. So that's about it for what I have to say. Next, we'll have Jenny Patterson, the Insurance Department's Life, Accident, and Health Legal Counsel, go into some of the details about what's in our network adequacy regulation that we have in force today, how it works. Jenny?
Thanks, Alex. I'm a little scared to take this mic, but hopefully it'll work for me. Can people hear me? Oh, good. Thank you. And thank you for coming here today. So what I'm going to talk about a little bit is what standards are actually established by the rule or regulation that Alex was talking about. But just before I start, a little bit of stepping back. As a lawyer, I can't help it, I apologize, but what's a statute, what's a rule? So we had the statute at the beginning, we had the slide up there. That is a law that's passed by the legislature. Oftentimes, the legislature will pass a law and not fill in all the details, but will direct an agency to fill in the details. So when Alex talks about the working group that the department convened in 2001, that was part of what we call the rulemaking process. And the rulemaking process involves the agency reaching out to stakeholders, trying to get a sense of the different interests and kind of balancing what approach should be taken to a particular regulation. And there are also public hearings as part of that process, and then there's a process through the Joint Legislative Committee on Administrative Rules. So all of that kind of goes into making a rule. Once the rule is properly adopted, then it has the force of law. So it can be enforced. It's one of the standards that actually applies to the insurance carriers or others in the regulated industry that the department regulates. So in terms of what the rule says, the core of the department's network adequacy rule is the basic access standard. And if you look at the language on the screen, it basically mirrors what's in the statute. The network has to have providers that are sufficient in numbers, types, and geographic location to ensure that all covered healthcare services are accessible to covered persons without unreasonable delay. And it's important to understand that this is an objective standard. The purpose of the rules is to make it clear to the insurance carriers what standard they have to meet so that they can then develop plans and networks that meet that standard. So another really significant part of the department's network adequacy rules is the geographic access standard. So the geographic accessibility standard, it sets very detailed requirements. And basically what they do, we'll get into them, and Michael Wilkie, who's speaking later, will talk about them in a little bit more detail. But basically they measure in distance or time of travel how close providers must be to covered persons. And again, since it establishes an objective standard, the standard is that for 90% of the people who are covered by the plan, that standard has to be met. It doesn't say that every single person has to be within a certain distance. It's 90% of that standard. So for example, for primary care providers, there have to be 2 within 15 miles or 40 minutes travel time of 90% of the covered population. For specialists, again, we'll hear in a little bit more detail later, it varies by specialty, but those distances and those travel times are a little longer. There are exceptions also. The rule allows exceptions to these geographic accessibility standards under certain circumstances. So, for example, if there are no providers in an area, there can be an exception, but in the case of that exception, the carrier has to take all reasonable steps to mitigate the impacts to covered persons. Okay, next slide. So a couple of other requirements in the rules. The rules also include a reporting requirement. That reporting requirement requires each plan, each carrier to file every March a plan, or actually a certification with the department that they have a network adequacy plan in place and that the standards are met. So that's something that comes up after the plan is operating, after people are being covered by the plan. They have to file that report with the department to ensure that they are in compliance with these standards. There's also a regulation that speaks to waiting time. Again, that's a part of the rules that's designed to be analyzed after there are people who are covered by the plan. And they have to meet what are called the NCQA standards. Next slide. A couple of things that are not in the rules. The rules do not require any particular carrier to contract with any particular provider. The department doesn't regulate healthcare providers. The department regulates health insurance carriers. Our role is to ensure that a customer that buys that plan gets the full benefit of the plan, that everything that's been represented to that consumer as being covered is in fact covered, that all of the forms and the documents associated with that plan comply with all of the many insurance laws. So those laws do not directly govern the contracting process. The rules don't require that any particular patient have access to any particular provider. So the intent is to allow the carriers to compete with each other on the basis of price, but also on the basis of network in terms of who is included within that particular network for that particular carrier. Okay. So this year, as we all know, is the first year that almost all of the provisions of the Affordable Care Act take effect. And because of that law, there have been some changes in what the department has to do with respect to some insurance plans, and specifically those plans that are being sold on the health insurance marketplace that's being operated by the federal government on behalf of New Hampshire. So just to step back, what is the marketplace? The marketplace is basically a website where consumers can go, they can buy plans. Those health plans are offered by commercial carriers. They're not offered by the federal government, they're not government plans. If a person is eligible under the standards that are set in the Affordable Care Act, then they can get a subsidy for those plans that they purchase through the marketplace to help them afford that coverage. So in New Hampshire chose not to operate its own marketplace. Instead, what we have is a partnership where the department's only role is its traditional role in regulating insurance. So we have always regulated the forms and the rates and the market conduct of insurance carriers. For the marketplace plans, we continue to do that. But there, again, are specific laws that have been passed about the Affordable Care Act. And one of those laws says that with respect to the marketplace, the state agencies, and specifically the insurance department, must accept all comers, basically any carrier who comes in and meets the standards to offer what's called a qualified health plan. That's the name for the plans that are sold in the marketplace, must be allowed to do so. And it's up to the carriers to decide whether that's something they want to do or not. And as we know, for 2014, only one carrier decided to participate. Because of the Affordable Care Act, there are also some very strict time frames that the department has to operate under with respect to these plans. And these are all laid out in a bulletin that the department issued last April, but they're also governed by federal law to a large extent. We can't really change them. So by June 1st, 2013, any carrier who wanted to offer a plan in the whole of 2014 had to file all of the details of that plan, including the forms and the rates and the networks, with the department. Then the department's role was to review all of that material, see whether it met the state and federal standards, and then make a recommendation, which had to be made by July 31st of last year, to the federal agency that was operating the marketplace. So there was a very limited window of time for the department to review all of this material, and it was a really big job. It was actually quite challenging for the department to get that all done. Then in September, the federal agency decided which plans it would certify to be offered on the marketplace. And then on October 1st, when the marketplace opened, all of the details of those plans became public. Now, typically, when the department reviews the forms and the rates, all of that material is confidential. There's actually a regulation on the books that says that the rates, in particular, don't become public until the plan takes effect. So even having them become public before January 1st, 2014, which was the effective date of the plans, was a change from New Hampshire law. Okay, so specifically with respect to network adequacy, the Affordable Care Act does require that any plan offered on a marketplace meet network adequacy standards. And those standards are very, very similar, at least the language, that language in the statute about without unreasonable delay, blah, blah, blah. It's almost identical to the language in the Affordable Care Act. So for New Hampshire, the decision was made that New Hampshire would apply its network adequacy standards that existed already to these plans. But there was one big change to what the department did from what it had done in the past with respect to network adequacy. And that was that for all of the ACA plans, there had to be this upfront review that took place during that very limited time period. That was really different from the way the department had typically approached network adequacy. If you remember, I said before, there was this annual report, and there still is, that continues to be a legal requirement, where the carrier would come in and say, for all of the people who are already covered by the plans, here is a certification that we are meeting these standards on an ongoing basis. And so that was a challenge because there were no consumers covered by the plans. And so what Anthem, who again was the only company who submitted plans for 2014, had to do was to use its entire enrolled customer numbers to look at the network adequacy of those plans because no one had bought them. We couldn't look at them and see. So there was no one to survey. There was just no data to fill in about how the plans worked in practice because they hadn't worked in practice yet. Now that requirement is still on the books, so all of the carriers will have to file March 1 as to their experience. There hasn't been much experience yet this year because the plans have only been in effect for about a month. Okay. So again, this slide speaks to the fact that there was a significant change in terms of the approach based on specifically the Affordable Care Act. And I just have one more slide, which again, just for background information, there are really two kinds of review that the department does. The first, as I talked about before, is the review of the forms and the rates, which all takes place ahead of time. We want to make sure that by the time an insurance policy is delivered to a consumer, that all the forms are readable, that everything that's supposed to be covered is covered, and that's why it took us so long to review these plans. We had to have people read through every single document and go through the rates. We have to look and make sure that the rates aren't so low that there's a danger that the carrier will become insolvent and aren't so high that it's unfair to the consumer. So all of that is one piece of the regulation that the department does. Then there's another type of regulation the department does, and that's called market conduct regulation. And what that is looking at how is the carrier actually treating the consumers who are covered by these plans. And so there's a difference in terms of the department's role in these two things. In the form and rate review, if the standards aren't met, then what the department can do is to disapprove that policy, and then it can't be offered. For market conduct, the department's role is different. The department can order compliance, can say, you are not treating this consumer fairly, you must now do so. So it's really a different type of review. So now we're going to have Michael Wilkie speak a little bit to the specific review process that was used for the marketplace plans.
Thank you, Jenny. Let's see how far I can pull this cord as I walk around. Thank you. My name is Michael Wilkie. I'm the Director for Compliance and Consumer Services at the New Hampshire Insurance Department. And one of the things about the Compliance Division, whether it's plans offered through the exchange and the Affordable Care Act or any other plan, is each and every single policy within the state has to be reviewed for compliance with our laws and our regulations. With that, the exchange products this year were no different. And part of that requirement is the submission of network adequacy. And this is kind of a unique year. And then one of the things I think it's very clear is that we had one carrier, Anthem, offering products on the exchange. This was an existing carrier with a strong market presence with membership throughout the state. And the primary focus really as we go through on this is really kind of been in 2014, the individual plans that are offered and to some extent small business plans. So with that, what happens with the compliance associated with it, and again, in 2015, we're anticipating at this point in time 3 carriers to participate on the exchange. So very, very different dynamics in 2013 for 2014 versus 2014 for 2015. What I'd like to talk about, and Jenny did a very good job of talking about the regulations per se, but in essence, what happens here is we require the network adequacy to be submitted by a carrier, in this case for the exchange and review under the ACA, And the two most important components, as you can imagine and was pointed out before, are the enrollees, where they're located, and the providers and where they're located, and what's the relationship that exists between them. As you go through, we look at 3-digit zip codes. We don't go down as far as to the 2-5 and definitely don't go down to the 9-digit zip codes, but in essence, looking at the 3-digit zip codes and where people reside relative to providers. We also look at the geo-access maps, primarily the summaries associated with those maps. We also look at certain qualification provisions. We look at certifications, attestations, whether they're NCQA or URAC, and those are certifications for insurance company vehicles, as whether they're certified or seeking certification. We also look at some of the contract provisions relative to whether or not there are termination clauses in effect. So all of these things are part of the overall submission requirement by a carrier under the network adequacy. As noted before, Jenny mentioned the time and distance, and specifically what we look for is to have 2 open providers within 15 miles or 40 minutes, and these are primary care providers, the gateway, the access, especially to the HMO products that we have offered here in the state. For outpatient mental health services, it's 25 miles or 45 minutes of travel. One of the difficult and challenging things that we have in New Hampshire is that we are very much a rural state. We don't have providers in every single county. We don't necessarily have 100% of providers in every single community. For the med-surg, lab, renal dialysis, and short-term mental health, the standard is 45 miles or 60 minutes. And again, we recognize that there's a rural environment. And for the one tertiary hospital, the one standard is 80 miles or 120 minutes. Again, what I think one of the important things is specialty, especially on the specialty side. Unfortunately, we do not have access to all specialties in every county and in every community, and we recognize that. So a carrier will, in essence, identify that. We will, in essence, check that against other carrier filings, look at the provider network pieces, and then realize that we have no authority from which to have that insurance carrier build a hospital, build an ambulatory surgery center, or put a provider in a particular location. So it's consistent for all. Just very quickly, kind of walk you through how that works at the insurance department. Straightforward flow chart. The issuer submits the materials into the compliance division. Compliance division reviews the information to see that it's all there. It, in essence, coordinates and then distributes, if the information is there, to other respective divisions within the department, to include our market conduct folks who are responsible for the detailed review of it and who share that information throughout. As we go through, we then review the adequacy report collectively. We review, make sure there are QHP providers, and look to see that there are essential community providers, and just kind of flowing through, we look at the access and the time and distance associated with providers, and from that review process, we then either make a determination as to whether or not we need to go back to the carrier for additional information. We then will look at this and say, if in fact it meets the 90% requirement as well as the other provisions, then it's our task to make the recommendation to the Center for Medicare and Medicaid Services, CMS, that the product be certified on the exchange. So with that, basically that's pretty much the process that's in place. Thank you. I'd like to turn it over to Tyler Brennan, our health policy analyst for the department.
Thanks, Mike. All right, I get to do some of the fun stuff. I get to talk to you about the considerations when you're developing this type of requirement. So we've got the law in the books. You've seen this before a couple times in our presentation. I want to bring your attention to the last few words. Accessible without unreasonable delay. The problem with these words is they're a little bit subjective. To somebody who lives in the North Country, driving 45 minutes to their local hospital, that may be perfectly reasonable. I live in Nashua, I work in Concord. If I had to drive 45 minutes to Concord Hospital anytime I wanted to get health care, I'm not sure I'd consider that reasonable. I'd be driving past 4 other hospitals to get there. So to the extent we think about reasonable access, it's something that needs to be worked out. The other challenge we have is this is a great chart with no numbers. It basically shows you that as you improve access, you also end up paying more. The costs go up. And we've been thinking about this from sort of a premium insurance perspective and the cost that we pay, or the amounts we pay when we buy health insurance premiums. But take a step back. Forget about health insurance for a second. Just think about improving access to healthcare services. We've got 26 hospitals in the state. Who says that's the right number? Why don't we have twice as many hospitals? Why don't we double the number of physicians? Why don't we get away from that exception for providers that don't exist in certain parts of the state? We could improve access dramatically from what we have today, but we would pay through it through our health insurance premiums and our taxes. So who says we have the right amount of providers right now? Well, it's somewhat subjective. The other thing is that insurance companies, they negotiate with healthcare providers. So they have representatives that meet with leadership of hospitals, they meet with independent physicians, they meet with other types of healthcare providers, and they argue about how much to pay. In the end, they come to an agreement, at least hopefully, where the rates are determined and the healthcare providers included in the health insurance carrier's network. If they don't reach agreement, then the provider is not in the network. The insurance company can't advertise it as part of the network, and the patients have to go someplace else. That negotiation, that plan, undesirable plan B, is what tends to control costs to an extent. So if the state required insurance companies to contract with every healthcare provider, you don't need to have a strong business background to understand how much leverage that would put into the provider's court. They could determine, well, gee, we haven't been paid much. We want to be paid more. I mean, what hospital or what healthcare provider couldn't find a good use for additional resources in the state? Probably all of them. So this is the challenge we face. The other sort of capacity consideration when you look at sort of access to healthcare services is that if it's just more convenient, people tend to get more healthcare. Healthcare providers want to be busy, and if you look at the cost of insuring hospital employees, they tend to be higher than most other employer groups. Why? Because it's really convenient. They're there. They're not just sicker. In some cases they are. There are two ways of balancing costs and consumer preferences. The first is the free market approach. We're going to rely on competition. We want insurance companies to compete with each other. That way the consumer can choose the best health insurance company and the product for them. And since consumer preferences vary, well, hopefully the insurance companies will figure out what people want at what price point. The other way we can control costs and balance consumer preferences is we can rely on our legislature and the government to make those decisions for us. We can do that through the legislation as the legislature is the decision maker. The insurance department will implement those requirements. But that hasn't really been the preference of New Hampshire in most parts of the country. To an extent, the free market doesn't always work out the way we hope it will. So there is regulation on the books that hopefully provides some level of balance, fixes inefficiencies within the market. And that's kind of what we have now. We have a statute that is intended to determine a minimum network that a health insurance company would have in the state of New Hampshire. One easy way we could bring down health insurance premiums is actually to do away with that requirement. We may all have to go outside of the state to get our health care, but we could get insurance for less. It's just not necessarily what you want when you're dealing with insurance. A lot of the times people buy their insurance products without really knowing what they're getting. So it's nice to have at least a minimum standard. So we've talked about access and cost a bit. Quality is certainly another major consideration. It doesn't help us to have access to a lot of healthcare providers that perhaps have never seen patients with the types of conditions we have. They have poor outcomes, that kind of thing. And indeed, when you look at the way healthcare has changed over time, there are certain specialized healthcare services that you want to get from very specific providers, and they're often not available in our local communities. You have to travel to get to those healthcare services. So to the extent we're developing standards to regulate health insurance companies, we want to make sure those standards are objective. That means we don't want Tyler's opinion versus Alex's opinion and somebody else in the department making it up as we go along. Those opinions may differ from yours, from the insurance companies and from the providers. So we've got a statute, we put down the rules, and we try to be as objective and clear as possible so the regulated entities understand what they need to do, and then hopefully the healthcare providers also understand what the rules do and do not do for them. We want to create a set of regs that allows insurance companies to compete with each other. We don't want to be so prescriptive that Anthem's products look exactly like Harvard Pilgrims, and there's no difference because they're all just complying with the law. We want to give them the flexibility to try and figure out what the market, what consumers, what patients really want. And sometimes they're going to be wrong, and nobody will buy their product. Sometimes they'll be right, and they'll capture more of the market share from their competitors. So it's a balance. You want to have kind of a minimum requirement, but you also want to allow enough flexibility so the carriers can adapt to changing trends, consumer preferences over time. We want to recognize how those consumer preferences vary over time. We also want to identify how the health system is evolving. The rules we put together 10, 12 years ago, well, they need updating, I think. Probably a lot of you do too. Whatever rules we come up with next, another 10 or 15 years, they're going to need updating again. The system is changing. In today's world, we've got hospital services, what we think of as hospital services. They used to be hospital services, available in lots of different locations. And you've probably experienced that. You've gone to your doctor and you thought, okay, yeah, I know I have to go to the hospital to get this done. And then they send you to an ambulatory surgery center, or you get your MRI at a freestanding site, or whatever the case is, you don't need to go to the hospital. On the other end of the spectrum, the hospital's not providing all of the high-end specialized care that you might have expected. Pediatric traumas go to Boston all the time. Other specialized services, they're going to need to be seen outside of your community. So to the extent we balance access, cost, and quality, we just need to consider how the system is changing. A lot of the specialized healthcare services are treated at what we call centers of excellence. You probably don't want to get a lung transplant in the North Country, and you're going to be perfectly comfortable traveling for that. So we just need to recognize how that changes. Even to the extent we're talking about primary care. Primary care is now available from providers that are not just MDs practicing in their own primary care practice. Nurse practitioners can do virtually anything a primary care physician can. You can select them as your PCP, and in many cases, they're less expensive. You can get primary care in walk-in clinics. New Hampshire is about to see a huge growth in terms of urgent care centers. There are going to be other walk-in care clinics. Many of these centers are going to be integrated with your primary care physician's office and the larger hospital delivery system that your primary care physician might be a part of. To the extent you can get primary care in a lot of different other locations, this is an important change in the way we access healthcare over time. So I would encourage people, particularly people thinking about a network adequacy requirement, to think more about access to specific types of healthcare services than about access to specific types of healthcare providers. Because that's going to change, and it's going to continue to change. And look at the last one, telemedicine. You no longer even need to be in the same location as the healthcare provider. You could go to a virtual center and get connected through telemedicine. Telemedicine is going to continue to grow. How do we develop a network adequacy requirement that effectively considers telemedicine? Not just telemedicine today, but telemedicine 5, 7, 8 years down the road. This is going to be a major growth area. So reasonable travel expectations for the commercially insured population. That's what we're dealing with as the insurance department. Why? Because we regulate commercial insurance. That's Blue Cross, that's Anthem, that's Harvard Pilgrim. It's not Medicare. So the question is, should we have different expectations for the commercially insured population, many of which is working, versus something different for other populations? And remember, our healthcare system is designed for people across all age spectrums and has actually fairly heavy emphasis on people over 65 because a lot of those people use services a lot. So should we think about this a little bit differently for a commercially insured population? We want to consider the population distribution, the density, and the demographics. Certain parts of the state have more kids. So we should have better access to pediatricians in those parts of the state, shouldn't we? What about certain population centers? What's the right number of primary care providers or providers providing primary care services, whether you think about the physician or other alternatives, in a particular area? like Nashua or Manchester. I mean, 10 or 15, that may not be enough. They may be only 5 miles from most of the people who live in those communities. But if you got to wait 6 months for an appointment, it kind of defeats the purpose of developing an adequacy standard. So we think about travel times. We also think about whether or not they're open to new patients. We also think we should think about how long it takes to get an appointment. And to an extent, our rules do that now, but they could do it better. We want to think about the mix of healthcare providers, and this goes back to thinking more about access to certain types of healthcare services rather than the actual type of healthcare provider. Because different providers are providing different services, and this is going to continue to evolve very quickly. So we're talking about doctors, we're talking about mid-levels, we're talking about hospitals, urgent care centers are going to play a big role, and ambulatory surgery centers. So there are a lot of considerations that we have when we develop a standard. And a lot of it is trying to figure out how much the competition within the marketplace or between insurance companies versus how much we want to regulate. And historically, New Hampshire's legislature has been hesitant to provide overregulation. And I think that's appropriate, particularly to the extent that things change over time, consumer preferences change over time, and we want to remain flexible and adaptable enough to deal with those types of changes. So that's a very quick summary of a lot of considerations. I'm going to pass it back to Roger, and we'll move on with the hearing.
Great, thank you very much, Tyler. Again, as I said earlier, the next step in the process is for us to take testimony from those of you that have indicated a wish to speak. You've all completed cards. I'd remind you again that keeping it down to 5 minutes or less would be preferable. We have about 30 people that have asked to speak. If you do the math, we're here quite a while, which is fine. I'm here for as long as you want to be here, or as long as they'll let me. This isn't my building. Let me also tell you that there are no breaks intended, that anyone that needs a quick break can do so by just getting up and leaving the room. We'll take questions after the testimony, but I'd ask that you write those questions down, and if you need the cards to write those questions on, Deb and some of her crew have the cards so that we can take the questions in some sort of order. And finally, again, as I said earlier, to wrap things up, Frisbee is going to make its presentation. So let me start with the first speaker, which is Peter Gosline. Peter, good morning and welcome. And with him is Michael Justice. Peter is from the Monadnock Hospital, and Michael is here with him. Right. Oh, I'm sorry. Please go to the podium.
Thank you. Thank you, Commissioner Savini and staff for allowing us to have this hearing. My name is Peter Goslin, and I'm the CEO of Monadnock Community Hospital in Peterborough, New Hampshire. We're a critical access hospital which provides millions of dollars in community benefits. Some of which are delivered through our extensive primary care network, our ER, our community wellness center, and other means. Unfortunately, we were one of the 10 hospitals that were not included in the Anthem Narrow Network announced last year. My brief remarks today will be focused on concerns regarding access, choice, and affordability for those in our service area who have been impacted by this decision. I will also introduce Michael Justice from our community, who's here with his wife, and he'd like to share his story as well. Two of the stated objectives of the Affordable Care Act are, number one, to make healthcare more available through increased access, and number two, to make healthcare more affordable, in particular for those who need it and cannot afford it. In New Hampshire, the current limitation of having only one carrier in exchange
and the subsequent narrowing of providers in the Anthem network have made the goal of increased access less achievable in our community. This certainly doesn't achieve the type of balance we just heard about, at least for 2014. We hear a lot from people who live in our service area about the hardship of giving up their doctors and also the hospital that they have sought out for care up to now. I can't walk into downtown Peterborough without being accosted by at least one person about this issue who's concerned about it. Accepting the standard that up to 10% of New Hampshire residents must fend for themselves or travel great distances for care, let alone what the weather is and whether they have transportation, is not what we had heard or imagined when the ACA was originally rolled out. In addition, delays in expansion of coverage for New Hampshire for low-income residents is making accessibility and affordability more challenging for everyone. We believe that there are upwards of 1,000 people in our service area alone who either have inadequate or no coverage and are thus left to experience episodic care when they are in crisis, and to seek care in unnecessarily expensive settings, for instance, like an ER. Ironically, our bad debt at Monadnock has increased 36% in the last 3 years alone, and at the same time, our disproportionate share payments, those payments originally intended to help pay for those who cannot afford care, have decreased 25%, or over $1 million during this time. I would strongly encourage state and third-party payers considering offering services on the exchange to consider these limitations as a serious threat to the health and well-being of our citizens and act accordingly. We believe there are options available right now to avoid these things. For example, this could translate into incorporating a higher percentage of essential community providers into networks, or alternatively, expanding access to additional local providers by providing for an affordable out-of-network benefit where trusted, capable local providers are not left out. This expanded coverage would enable more of our citizens to be provided insurance at affordable rates, and consequently, they could avoid being needlessly separated from their caregivers, who have in many cases treated these people over a long period of time and who really know them best. This is not only just the right thing to do in a civilized society like ours, but it can be literally life-saving in certain cases. We at Monadnock Community Hospital are also betting that the Medicaid expansion compromise announced by the House and Senate last week will translate into legislation that will be signed by the governor soon. This will affect approximately 50,000 of our most vulnerable citizens. This is a real problem with a real solution that our elected officials really should act upon immediately. Today, I'm here to introduce Michael Justice, who has been impacted personally by the delays in solving these problems. This is not a political problem for him. This is a real life problem, and he and his wife need some immediate help with it, as you will hear shortly. I'd like to introduce Michael Justice, who lives in Peterborough, not far from Monadnock Community Hospital. He'd like to tell you his story.
I want to thank you for the opportunity to be here today. And basically, I'm going to tell you our story and how I've heard from others about our story. Our story from 7 years ago had as good an ending as it could have. If the same events were to happen today, the outcome, more than likely, would be an ending. On February 14, 2007, 3 days away from my 57th birthday, it was snowing hard and I had been clearing the driveway. When I went inside, I knew that something very, very different was happening to me. Hardly any pain, profuse sweating, trouble catching a breath. My wife, Chris, and I were going to run errands before the snow got worse. Schools and work were canceled. At the post office, I asked her not to panic, but drive to the hospital, minutes away, even in the storm. I thought someone in real danger might need the ambulance. The hospital was Monadnock Community Hospital in Peterborough. Our doctor's office was there too. It was 3 miles from our house, less than 15 minutes away, even in snow this heavy. We both had complete confidence in MCH because Chris successfully underwent emergency surgery there on a Saturday morning the previous autumn. On this day, I was having the heart attack I wasn't supposed to have. I was very familiar with heart disease, My grandfather, my father, and several uncles died from it. I had determined to follow a different path. I had been a runner for 3 decades, completing a couple of marathons and several half marathons. We ate healthfully. I did work that I was passionate about and believed in. With good health insurance through our jobs, we took advantage of regular medical checkups and preventative care. In 2007, MCH first saved my life and then stabilized me for the long ambulance ride over snow-covered Temple Mountain to the New England Heart Institute in Manchester. There, another skilled team, already prepared, repaired me for more life. Quick, accessible, and comprehensive care prevented damage to my heart muscle. Soon, the effective, proven cardiac rehabilitation at MCH continued my rescue. At the beginning of the program, I was afraid that my now life would never resemble my then life. By the end of rehab, I was running on a treadmill. A New England Heart Institute cardiologist follows up with me annually and locally at MCH. In 2007, immediate access to skilled health care and rehabilitation gave me more life. We are grateful each day for the blessings of that time, of that place, of those people. The New Hampshire of 2014 would not replicate this outcome. Today, our only viable health insurance option is the WellPoint Anthem Marketplace. Despite ongoing promises from government officials before and after its launch, the WellPoint Anthem monopoly in New Hampshire cost us our doctors, our established preventative and wellness care, our hospital, and that hospital's pain management and physical therapy programs. In January, as required, we paid the first premium to WellPoint Anthem. We'll pay it again in February and in March before we have the first available appointments with a potential new primary care doctor. This office is 30 miles, or 51 minutes driving distance from our time, one way, in good weather, if you're healthy. If my cardiac event of February 2007 were to happen in the reality of 2014, if I were to have the same symptoms without the lessons gained from a previous heart attack, if a snowstorm canceled school and work because driving was too treacherous, and if I had no doctor and no history or association with a hospital, I would decide to sweat it out, literally, at home. A very bad decision. If I survived, the damage to my heart and or other organs would be severe, and I would remain without a doctor or a local cardiac rehab program. As negatively impacted as we are by New Hampshire's implementation of the ACA, our story is anecdotal. The focus should be on all of us, on our neighbors, families, fellow citizens, whose health has become or will become endangered by the exclusions granted to WellPoint Anthem. Article 1 of New Hampshire's Bill of Rights declares that all legitimate government is, quote, instituted for the general good. The state has maintained that the rules have been followed. Those rules represent an arbitrary and perhaps immeasurable requirement to serve, quote, 90% of the enrolled population, as self-reported by the insurance carrier. Even if rules were followed, how do the harmful inequities exemplified by WellPoint Anthem Marketplace pass the, quote, general good test? What if similar rules were applied by other jurisdictions? What if the Department of Transportation decided to eliminate snow plowing or maintenance on state roads in Concord, Peterborough, Exeter, and all of Sullivan County? What if the Attorney General's office or the state police decided to stop enforcing and prosecuting laws in Nashua, New London, Portsmouth, and Littleton? What if the Division for Children, Youth, and Families decided that child abuse cases in Manchester, Berlin, Salem, and Lebanon would not be investigated? Or what if selected areas of the state were charged more than others for the same services? In 2014, New Hampshire, an arbitrary percentage of citizens has been recognized as legally excludable from the same access to health care as others paying identical health insurance premiums to the same company. Access to health insurance does not equate with access to health care or well-being. It's not hard to imagine two-parent or single-parent families in New Hampshire working multiple minimum wage jobs without insurance benefits. Recently released statistics document that 72% of the first 11,500 enrollments under the ACA in New Hampshire were eligible for financial assistance. If such a family lives in Peterborough and exercises their only health option, Bell Point Anthem, where do they go for health care? How do they get there? How much does it cost them in lost wages to drive to Keene, Milford, or Manchester? How do they manage with a child in a hospital 30 or more miles away? How would you? Moreover, how much does it cost them to miss out on preventative care? How much does it cost us as a state to endorse roadblocks to that care? How much does it cost us as a community when a child's undiagnosed stomachache turns out to be advanced appendicitis, or when a young man's groin pain is ignored until it is diagnosed as later stage testicular cancer, or when our mom or dad goes untreated too long for diabetes until its deadly complications multiply too far? A report from the Subcommittee on Primary Health and Aging of the U.S. Senate, Committee on Health, Education, Labor, and Pensions, dated January 29, 2013, cites that, quote, as many as 45,000 people die each year because they do not have health insurance and do not get to a doctor on time, end quote. That's what it costs us, the equivalent of 15 times the casualties of September 11, 2001, each year. How powerful and united was our justifiable outrage by that horrific day of tragedy. No effort or expense has been too great for our government since. Our state's well-being is not served by the current implementation of a single ACA marketplace provider. Can we allow divisive partisan tactics, the deafening repetition of crafted sound bites, to divert us from doing right? We can stand up as neighbors, as families, as patriots, and refuse to accept a single death from the current inequities that compromise our health care. We can fix this. We can find a solution before the cost becomes too high in human suffering. Whose lives are we going to save today? Thank you.
Thank you, Michael. And thank you, Peter. Our next, the next speaker is Stephen Spratt. And again, I would remind you that if we'd like you to try to keep it to 5 minutes. If all of you that have asked to speak are going to be able to speak for the length of time that I have this room. We do have some assistance right here. If those of you speaking, Karen is going to hold up a sign when you're getting a little close to your 5 minutes. What I'm also going to mention is that in addition to any testimony you give today, I would welcome any written testimony you have. And if you can't stay because the time gets too long and you didn't get to speak, I would welcome you giving written testimony instead of verbal testimony. So again, we want to hear from everybody. If it's here this morning, that's great. If you can't, then we'd love to hear from you in writing. With that, I'll turn it over to Stephen.
Thank you, and I'll be very brief. I'm an insurance agent in New Hampshire, and I think that puts me in a unique role because I really care about the consumer. I'm not standing here defending Anthem. I'm not standing here defending the other insurance companies or the law. But I see both sides of the story, and it's I've specialized in health insurance for 10 years in the individual market, and I've seen all the hardship. I've seen folks that cannot afford to buy insurance. I've seen folks that have gone without insurance, and frankly, I wasn't that excited when the Affordable Care Act came out because I was concerned about what it was going to do to affordability of insurance here in New Hampshire for some people. And I can tell you I've got 700 or 800 clients, so I see both sides of the story. The Affordable Care Act, by the way, I put 150 applications through in the month of December. And I enrolled every single one of them myself. I helped all those folks because the website was a disaster. And it was very exciting. As a matter of fact, I felt terrific when I was able to help people get subsidy. It was really cool. I've had folks that are elderly, maybe near retirement, that can't find a job, that have been borrowing from their retirement accounts $1,000 a month to pay for their health insurance. because they did not have access to affordable care. And now with the Affordable Care Act, they were able to purchase insurance with subsidy for $1.76 was one client. Maybe that's a little extreme, but the fact is, so for folks that have been struggling of trying to buy insurance for their families, the Affordable Care Act has been in some ways very good. I think the problem, though, is the problem of competition. And we don't have the competition we need now. And that's because the other companies chose not to participate, not because they couldn't. And I understand that next year comes and they'll be able to. But without giving the insurance companies the ability to keep costs under control, these costs will continue to spiral out of control, and those folks that have insurance now won't be able to afford it. Right now, there's a lot of folks that got to extend their insurance benefits until next December. Those folks are going to find out when their rates go up and their networks are narrowed. They're not going to be very happy either. But there are other companies. You know, it's not just Anthem that offers insurance in New Hampshire. We have other companies that offer national networks where folks can get insurance and they can go to Mass General Hospital if they want. I place a lot of folks with them. Now, I will admit, and I will tell you that if you want a broader network, that company, the other company that offers insurance here in New Hampshire, offers plans where you can use a national network, but the plans are 50% more. So without competition or with a national network, that's the other side of the coin, is that we may have insurance that's not affordable to anybody. Now, I have a lot of clients, and some of them near and dear to me, that have had to change providers, and it's not easy. But you know what? It wouldn't be easy if they were paying 50% more for their insurance either, and that's what's going on right now, is that's the other option if we don't find a way to keep insurance costs in control and give the insurance companies the ability to negotiate and get concessions from providers. So that's what I got to say. I really care about all those consumers out there, and we need a solution that is not so narrow-minded as to exclude the rest of the consumers. Thank you.
Thank you very much, Stephen. The next speaker is James Miller.
My name's James Miller. I'm a New Hampshire native. I live in East Wakefield, New Hampshire. And Commissioner Savini and members of the New Hampshire Insurance Department, I thank you for giving us this opportunity to voice our concerns, and I appreciate your willingness to listen. I'm here because I'm concerned that a single corporation, Anthem, which is currently our only option under the Affordable Care Act, may be using its commanding position to limit choices for our citizens. I know that limiting my choice of providers is solely a decision being made by a large corporation. One of Anthem's reasons for this decision has been reported as being economic, but I'm puzzled because my experience is that Frisbee Hospital charges lower fees than a Dover hospital that I'm now required to use. I have evidence of this that I can share should you request it. The larger issue here that I hope your department will wrestle with is whether it is to stand by the people or yield to the demands of big business. Your department's mission statement clearly indicates the importance of promoting and protecting the public good. I'm concerned that allowing big business to limit choices is inconsistent with these goals. In our democracy, it's often tempting to allow the free market to determine services and costs applied to an industry. But there are situations such as this one that require government intervention. For example, I must have health care and health insurance. At the moment, I must have Anthem as my insurance company. I have no other options. Anthem currently has a monopoly on this market in New Hampshire. This type of situation requires government supervision and, within reasonable limits, controls. We only need to look at the past decade to see how poorly the free market has served the people on the health care issue. The sickest people were denied health care. The skyrocketing cost of premiums placed health care out of reach for so many families. We've been repeatedly shown that corporate America cares only about itself. This was the primary reason for the Affordable Care Act. I believe that health care is a fundamental right for every family. Their choices of doctors and treatment facilities should be their own. Corporate America has no right to limit access. I ask you, Mr. Commissioner, to please contemplate whether there is more that you can do to promote and protect the public good by using the power of your office to create more choices for the citizens of New Hampshire. I'm trusting that you and your department will find a way to ensure that the freedom to make choices concerning healthcare services remains in the hands of the patients and their doctors and away from corporate boardrooms. Thank you.
Thank you very much, James. Appreciate your comments this morning. The next speaker is Greg Hopkins.
Good morning. I'm a partner at an insurance firm in Rochester, and I deal with a lot of the community on an individual basis and have tried to help address some of the questions and concerns that have come about through the Affordable Care Act over the last couple months. And like everybody else, it's been a very confusing time. And to come up with an answer of why you don't have a choice has been puzzling me for quite some time. And I think that's a reason why a lot of us are here today. To sit in front of somebody and tell them that, yes, you can save some money on your insurance by going through the Affordable Care Act, but you can't go to the place that you've always gone to, and you don't have a choice of going to the place that you're used to going to. It's very tough to do to a person who lives, and I'm not sure if you're all familiar with the area up there, but lives like in Wakefield. And there's not a hospital that's that close except for Frisbee. Frisbee's right down the road for them, and Frisbee's been there for a while, and it's easy for them to get to. Now they have to drive all the way into Dover, and for a family that works 7 o'clock in the morning until 5 o'clock at night and has a kid in school and maybe has one car, we're talking about an area that is not maybe as fortunate as a lot of other areas, and hardworking blue-collar people who are looking forward to getting this benefit of a reduced price in their health care. And now telling them that, yeah, you could save some money, but you've got to go way out of your schedule or take a half a day off from work just to go over to the doctor that might be an hour away for you, or 45 minutes anyways, is really tough for me to sit in front of people and tell them. So like Jim, who put it very well, I'm hoping that, Mr. Commissioner, you can look at these situations and help people provide choice, again, to them, and make them feel comfortable about what's going on in our country and about what's the people that lead us. And speaking of leaders, I can't say enough about Monadnock Hospital and Frisbee Hospital for stepping up in their communities as leaders of a community. And let's face it, a hospital is a leader of a community. And I know from dealing with Frisbee Hospital that they put together a bus of people to come down here. And it wasn't to benefit Frisbee. It was to benefit the community. It was to stand up as a leader and to stand up for their rights and to let them know that, hey, we believe in choice too, and that you should have the choice of your provider. And I hope that you can realize that in making your decisions in the future and help us all get back our choice. Thank you.
Great, thank you, Greg. I've got cards from Jeremy Eggleston and Al Felger. I'm assuming that that's for the presentation at the end. Okay, good, thank you. Next, I'd like to ask Senator Andy Sanborn to come up and speak.
Mr. Commissioner and members of the panel, thank you so much for doing this today. We truly appreciate it. And obviously I want to give a huge shout out to Al and Peter who are really defending their communities. And again, it's very, very, very kind of you to do that. How many people in this room lost their doctor or their hospital this year? I lost my doctor in my hospital too. After 27 years of seeing the same doctor, after 11 significant surgeries, my wife and I were told, like many of you, that we could no longer see our doctor and we could no longer see our hospital. I recognize a lot of the intellectual arguments that can be made to try and comply with the challenges put forth by the Affordable Care Act. I recognize the challenges that you all in the Department of Insurance and Anthem and everyone involved has been struggling with in order to try and solve the problem. I also recognize that this is a problem that's been coming down on us since essentially 1993, and through the policies enacted by the legislature, we have continued to see less competition. We have continued to see less access, and we have continued to see higher costs. You know, today in the state of New Hampshire, we have the second highest cost of health insurance in America. Today in New Hampshire, we have the second highest cost of health insurance premiums in America. And today in New Hampshire, we have one of the lowest levels of access with one carrier, and we've just shut out 10 of our hospitals. I submit for your consideration, are these the values that we have in our state? At what point do I ask you to consider and recognize that the policies you continue to put forth, that many of you up there know I've been fighting against since the time I became political, just aren't working? We need more competition. We need to have the capacity to find insurance across borders, just like we do with car insurance, just like we do with health insurance or your home insurance. The argument of adverse selection, the argument of always trying to comply with the laws in our state just aren't working. I ask you to consider all these people sitting out here today who have lost their doctors, who have lost their hospitals. When I think about the solutions of what we could do and the challenges we're seeing across America, I hear very few states celebrating the fact that they have the highest cost of insurance and some of the lowest access. I ask you to consider this year to start supporting the policies that will bring down costs, which means actively coming out and supporting cross-border insurance policies, specifically advocating for more carriers. And yes, recognizing when you have phenomenal hospitals like Rochester and like Peterborough, allowing them the opportunity to participate in caring for their friends and their neighbors. And with that, I conclude my testimony, and thank you very much.
Thank you very much, Senator. Next, I'd like to ask Lisa Kaplan-Howe to come and speak.
Good morning. Move this down a little bit. My name is Lisa Kaplan-Howe. I'm the Policy Director at New Hampshire Voices for Health. We're a nonprofit consumer advocacy organization, and together with our 50 partner organizations, we represent over 375,000 people in the state of New Hampshire. I want to first thank you for having this hearing and for letting us all provide comments. I will try to be fairly brief, and I do have written comments that I can provide. We think this is a particularly important time to be revisiting our network adequacy standards in the state and understanding how they work in practice, both because of the introduction of a new narrow network in New Hampshire, but because many more people in New Hampshire are now gaining access to health insurance. And we understand that the introduction of the narrow network product was an attempt to, or is an attempt to, control rising healthcare costs by a private company. And those are certainly concerns that we share. We understand and we hear all the time about the impact that unaffordable premiums have on people's ability to afford insurance and therefore to access care, and also on their financial stability and the financial stabilities of companies that offer health insurance to their employees. So we think that narrow networks, if they're structured properly, can be an appropriate way to control healthcare costs, and really encourage you to take a close look at that, at how they're structured, and that the balance is achieved between bringing costs to a more affordable level and making sure people have access to the healthcare that they need. We welcome the opportunity to have the stakeholder working group and really appreciate your willingness to do that. We would welcome being part of that and also helping you think about who would be appropriate people to have as part of that, including people representing consumers in affected communities and also with particular disease conditions, and also representatives from the provider community. As you go through that process, I did just want to flag some of the concerns that we've heard raised regarding the new networks in New Hampshire, so that they're something you're thinking about. Including what's the experience of obviously the individuals living in the communities where the hospitals are not included, not only their access to hospital care, but also other providers. Also, what's the experience of individuals living on the state border who may typically get care out of state and may no longer be able to? What's the impact on vulnerable populations, including those who are now newly accessing more affordable health insurance? What's the impact on access to mental health services? We, for some time, have had a shortage in our state of inpatient beds for mental health services, and also we have been hearing about extended wait times for outpatient mental health services. Do the drive time maximums hold true in typical traffic patterns and in winter months? And are the NCQA standards for wait times appropriate and provide people with the access that they need? And as was mentioned earlier, another way to approach this could be looking at maximum providers with open panels to enrollee ratios inside networks. And finally, is the requirement of access to out-of-network providers at the same cost when there aren't appropriate in-network providers available being approached in a way that's working for folks. So in addition to the concerns that we've heard raised about the existing networks, just some other broader considerations we hope you'll take into account as you think about your standards more generally. Access to care within reasonable times via public transportation, which is particularly important for folks who may be getting some of the new subsidized insurance. Access during non-business hours. Also, do the standards align with the new essential health benefits, including access to pediatric, dental, and vision care? Is there appropriate and adequate access to essential community providers who probably have existing relationships with some of those new people accessing health insurance? Continuity of care requirements right now have a pretty limited application, and should that be made broader so that people have the ability and the time they need to transition their care? Also making sure there are standards for out-of-network care in emergency situations, and also when you may be going to an in-network hospital but be interacting with providers who are out-of-network. And again, making sure that the enforcement protects vulnerable populations. So I have it all in writing, which I will provide you. Thank you again for this opportunity and for the opportunity to continue working together to make sure the right balance is being achieved.
Thank you very much, Lisa, for your comments. Appreciate them. Next, I've got Dr. Deborah Harrigan from Frisbee Memorial Hospital, but let me ask, are you part of the Frisbee presentation, or do you have independent comments? Okay.
Hi, I'm a little nervous. I'm a primary care physician in Rochester. I've been in the community for 14 years. Several of my patients are here today, actually. None that I've had to say goodbye to, though, unfortunately. I think the comments that I'd like to make are regarding the costs associated with having to change doctors. Every time that I take on a new patient, I spend an hour with that patient to meet them, review their records, and I don't know that requirements of having people have to change, you lose a lot of the richness of the continuity of that relationship, and you lose a lot of the data points because the electronic health record is so hard to read. There's not a good data transfer from one provider to another provider. The amount of time that you have to spend to go between each of those records is just a lot of cost, and I don't know if that's something that could be considered as you continue to think about network adequacy and continuity of care for patients and their physicians. So thank you.
Good. Thank you very much, Dr. Harrigan. Appreciate your thoughts. Our next speaker this morning is Arthur Davis, a Rochester citizen.
Thank you, Mr. Commissioner, for allowing me to speak. I'm a citizen. I'm not affected by this law. I happen to be in an age group that was protected by the government in the mid-60s and enabled us to benefit from the discrimination against the rest of the population. I believe in the strict application of the equal protection law, and I suffer with the exceptions created by our courts, such as rational basis or strict scrutiny. I think that the Equal Protection Clause, which is applicable to state action, is being violated by the implementation of this law. I understand that the U.S. Supreme Court upheld the law as constitutional as a tax, even though most of the arguments centered on interstate commerce and Congress's authority to regulate interstate commerce. But upholding the law is one thing. The implementation is another. I believe that the way it's being implemented in New Hampshire, through unintended consequence and the de facto monopoly of Anthem, is discrimination. And if it isn't discrimination under the 14th Amendment Equal Protection Clause alone, the fact that people entitled to subsidies are required to leave their home community and home hospital to get care or lose those subsidies, it has a chilling effect on what otherwise is a right to choose where they're treated, by whom they're treated, and in effect choosing to contract with whomever they choose to contract. In effect, I understand there's a mandate, and this is probably the first time in our history that we have had a mandate to purchase a particular product or be fined for not doing so. I believe that the insurance department has been put in the middle by the state government, who's abdicated from its responsibility to enforce the Equal Protection Clause. And I think that the standards you've used, such as the 15-minute, the 40-minute, 15-mile criterion, the 90% population criterion, doesn't work anymore. It's, in effect, over the 5th largest community in New Hampshire. Rochester is the 6th largest. Rochester, because of its open space, has more capacity and potential for population growth than Dover does. I don't have the statistics, but I believe that that is true. Allowing Anthem to have free rein on what it does and who it chooses to include or exclude is absurd. It gives them power to determine the economic development of huge population centers in our state. That is wrong. The Insurance Commission cannot allow it. You've got to change the regulations. You've got to achieve the purpose of the act, which was to include more people, not to exclude people, not to disrupt people. In effect, hospitals are charitable nonprofit organizations. Most of the people in their communities support those hospitals. To the extent you're forcing all the people entitled to subsidies to another hospital out of their home community, has a terribly disruptive effect on their home hospital, its continued existence, the quality of care it can offer, and the funds it can raise. Because all those people who you dislocate to Dover are not going to be making contributions to their home hospital. I thank you.
Thank you very much, Arthur. Appreciate your comments this morning. Next is Dr. Richard Capello from Frisbee Memorial Hospital. I assume that your comments are also independent of the... Okay, thank you.
Hello, and thank you for giving me this opportunity. I've been employed by Frisbee Memorial Hospital as a primary care physician for 7 years after leaving 20-plus years of private practice and being unable to continue in the private practice arena due to all the constraints and financial things that have been placed on us. So I came up here, entered into a system that has allowed me to continue to practice family medicine, and the hospital itself and our outpatient clinics have met or exceeded all quality initiatives, all quality guidelines, delivered a product at a reasonable cost that would allow us to think that once federal money comes into the program to allow us to fix all of the injustices that our patients have had to endure with being denied care when they've had multiple illnesses that the insurance companies have enjoyed for so long. They've been able to exclude people so they can drive profit. Once our federal tax money got into this mix, we would have thought that as a hospital system that's providing care that's equal to or better than a national standard at a cost that comes in equal to or a little bit below what the cost is to deliver that care, that's reached out into areas and put primary care doctors into areas that other places have not wanted to do, and done that at times at a loss, that when we finally got an opportunity to enjoy covering patients that haven't been covered before, or my middle-class families who are two working people, as the other gentleman said, maybe sharing one car, who have to work in order to keep their coverage, their feeling is fear. They don't know whether they qualify for subsidies. They don't know whether they can budget moving ahead into the next year, whether they can make $1,000, $2,000, $5,000 deductible. They are extremely unsure of what to do. I've already lost patients who have said to me, I don't know how I'm going to get to these physicians that I have to go see. So before federal money, Tyler, you did a great job outlining how we got to this problem, but now there's federal money involved, and the insurance companies are going to enjoy that federal money. Why are we being excluded until the dust settles? Let's let this shake out and reward these hospitals that are doing what they're supposed to do and doing it at a reasonable cost, and not allow our patients to have to ration care. So they might just make their premium. They don't know whether they're going to get a subsidy to help them make that premium, and then have to ration their own care to decide whether they drive 40 miles to go see the doctor when they're sick. I mean, they should at least enjoy a reasonable deductible for the amount of money they're paying for the care they're being given when our tax dollars are going to the profits on the insurance side of this. I don't buy the entire argument of cost containment when federal money is now subsidizing a company. We need to look at what the cost containment is, who is benefiting from cost containment now. Before the federal money was involved in this, I could understand every argument Tyler had as to how we got to this problem. But now that federal money is involved in this, I would really like to know how we keep the mantra of cost containment when our hospital is doing everything it can. We're preserving jobs, we're not firing people, we're keeping people working in this community who are now being forced into a network with high deductibles. It's not really cheaper than what they were getting. So I would ask that mantra of cost containment that we continually hear be better described to us as to who's benefiting from the cost containment. And that's my end of my presentation.
Thank you very much, Dr. Capello. Appreciate your comments this morning. Next is Dr. Evan Greenwald from the Counseling Center of Nashua and the New Hampshire Psychological Associates. Dr. Greenwald.
Thank you very much. I'm here really to talk about behavioral health care access, which is often the forgotten stepson or daughter of the medical system. Annually, 12 to 15% of consumers typically access behavioral health care services, which is probably why it doesn't get the level of priority that it deserves, although recently, certainly it has in the media a lot with emergency room issues and things going on in the behavioral health community. I want to briefly touch on inpatient care, but my large focus is also on outpatient access to care. The publicity has clearly spelled out the level of problems. On the ground, when you actually attempt to call and get a patient into a hospital, beds are filled. There is no access to care anywhere in the state. 2 weeks ago, I called local hospitals searching around myself for a patient who needed hospitalization, and there were no beds available in the state of New Hampshire, period. That is a serious problem, and the question is then what happens to those people? I then called the emergency room and said, what happens at Southern New Hampshire, which happens to be one of the hospitals excluded from the narrow network? And when I called and I said, so if we send a patient over to you and you need to hospitalize that patient, what do you do? And they said, well, we call around. If we don't have a bed available, we get a personal assistant who sits with that patient in the emergency room for a 24, 48, 72 hours, whatever it takes, days, waiting for a hospital bed somewhere to open up. That is a significant problem that I think was unfortunately ignored in the process of the more limited network. And I certainly understand I'm a free market competition kind of guy myself. But I think, unfortunately, in looking at the hospitals that were excluded, Frisbee had 10 geropsych inpatient beds that have been eliminated from the network. Southern New Hampshire Regional had 12 beds. I think they've now dropped it to 9. There's a loss of psychiatric beds in the state. And I know that when I talked to Mr. Wilkie at some point in the fall, he was unaware of the fact that excluding Southern New Hampshire at that point cost inpatient beds. And I just think it's, again, the forgotten stepson or daughter of the whole medical plan design, and it really needs attention. Since Lakeshore Hospital and Charter Brookside left the state in the 90s, for those of you who have been around long enough to know that, there generally has been a shortage. There's also been a transition of care into outpatient settings, as it should be, and the more appropriate outpatient care delivered, obviously the less inpatient hospitalization is needed, and I'd like to transition my focus to outpatient care, because without access to outpatient care, you actually increase the demand and the need for inpatient beds. I appreciated the presentation early, and it was informative to understand the geo-access issues and the kinds of accountability that is intended to be used to scrutinize insurance companies across the board, and I'm not singling Anthem out in particular. But the reality is, when you're on the ground dealing with behavioral health care, and if you surveyed a number of consumers, you would quickly learn that it's not, although part of the issue is geo-access, and part of it is geographic proximity, and part of it is drive time. It's the what was referred to as the wait times that are mandated by INS 2701.07 that really is the critical issue to care, and really is the critical issue to consumers. People will drive. They will drive the extended times if they can get an appointment, but we still have a problem just getting in to see somebody. And it was interesting to hear that most of those accountabilities are done after the fact, although with the Affordable Care Act, they had, in some cases, the geo-access design had to be done in advance. But I'm here to say that it should always be done in advance, and it isn't difficult to predict, because the reality is that every year, I've been in the state of New Hampshire for 25 years now, you know what the access is. There's not a flood of new psychiatrists coming into the state. There's not a flood of new psychologists. If you looked at the number of new medical licenses issued, it's relatively stable, plus or minus 1, 2, 3, 5 a year, whatever the case may be. And mandating and requiring insurance companies to prove they have access up front, and then enforcing that by limiting their capacity to sell insurance or make change, is ultimately the free market solution that will make a difference. Because what those insurance companies will do is what happened personally with me in the mid-90s when Charter Brookside and Northeast Psychiatric Associates went out of business. I got a call one day from Cigna Healthcare saying, can you handle 500 transfer patients, psychiatric patients, for outpatient care? There was no way I could, and I said, no, but will you help me? Can we work together for a solution? And their answer was, sure, what do you need? And they loaned me $25,000. An insurance company loaning a provider, a national insurance company loaning $25,000 is unheard of. And the bottom line is that will make a significant difference if the department enforces limitations in insurance sales, enforces insurance companies to improve their access to care in certain regions, and measures literally those NCQA standards for time. And most people don't even know, it's not written into the regulation what those are. 6 hours access for emergency outpatient care. Urgent, 48 hours, or maybe 72. And it's 10 business days access to routine appointments. I called in October every single community mental health center in the entire state and asked them, I have a patient, I need to refer for a psychiatric evaluation. How long will it take to get somebody in? The best I got was 2 months, and the worst I got was 6 months. So anywhere between 2 and 6 months is the current reality on the ground of what it takes to get someone into care. And I think that with the departments pushing back on insurance companies, in fact, change would happen. Rather than just complain, there are a few specific solutions that I would like to recommend. The data that was provided by Anthem, which you have in your packet, I specifically looked at and spent time with. I got their geo-access data, the same data that was provided to the DOI. It's not accurate. There is no objective verification of the data, and I'm not saying that Anthem in some way misrepresented that data. It may be an inaccurate database. I can tell you that the providers from my practice at the Counseling Center of Nashua do not practice in some of the regions which are represented on the data they sent to you. The practice locations have been closed for years. They've moved and relocated. And there really is a need for accurate data. The New Hampshire Psychological Association is also attempting to collect information on access to behavioral care. We've sent Mike Wilkie a sample of what we'd like to do online for consumers who are waiting to hear from the DOI about whether they will partner with NHPA in order to get data that can actually be used that is accurate and objective. And
Doctor, if you could submit any additional comments in writing so that we can allow the rest of the speakers, we still have many speakers that want to provide testimony this morning, we would appreciate that.
Okay, I'd just like to make one final comment then. The continuity of care provision is very important. The spirit and intent of that provision, 2201.10, is an awesome, a very good provision that the Department of Insurance implemented in New Hampshire. It's rare across the United States. It allows a transition of care benefit for up to a year. The spirit and intent of it was if an employer switches insurance companies on an employee, that it would allow, since to no fault of the employee's own, it would allow them to transition to stay with their existing provider for up to a year. That has not been enforced with the new ACA plans. That would help at least temporarily with access to care, and it would allow the system time to adapt to the new changes in the marketplace. And the reality is that the small group employers, many employers are sending all their employees to the marketplace. So as Tyler had pointed out, the environment is changing. It's not just the individually insured, it's now employers who are also sending them, and the same provision absolutely should apply in that case. Thank you.
Thank you very much, Doctor. Really appreciate your suggestions. The next speaker is George Lovejoy. George? Questions we have so far. That allows us to do that.
Good morning. Commissioner Savigny, members of the panel. My name is George Lovejoy, I live in Barrington. I'm a former state senator, and for many years I served on the Rochester School Board and on the Rochester City Council. You know, at 11 years old, my appearance in Rochester occurred about the same time when Frisbee Memorial Hospital was founded in 1942. Over my lifetime, I've had many visits to Frisbee, and if it were not located where the facility is now, as well as the high constant care standards they have provided, I'd not have been able to be here today to testify before you. I'm still a patient of Frisbee, and the outstanding doctors and staff who are there now. It's a first-rate medical facility with cutting-edge doctors, and one of the major reasons the area has good and positive growth. Downgrading the facility while experimenting with managed health care has a potential of negatively affecting the whole area's economy. Not only with the jobs lost at the hospital, but also by removing one of the major reasons that businesses as well as workers are attracted there now. Anthem, the only insurer in the state to participate in the state-federal partnership, has decided that Frisbee Hospital is not to be a participant. Not to be a participant of the healthcare network, and by dictate, has the potential of losing upwards of 7,000 of their clients. And those 7,000 will have to travel to another city to get covered care with doctors who are new to them and in surroundings not familiar. In exchange, we're told, those hospitals who are selected would be required to promise that they will charge less for covered services. In doing so, affordable care becomes unaffordable for the client. Those who have to travel, if they can find the means, will have to pay added expenses as well as for time lost. The hospital that has suffered loss of clients will have to make up for the loss of revenue or cut the number of quality of services provided. The hospital who receives the new clients and had to promise to provide more services for less money is an untested theory. And so it has all of us following a bouncing ball. The one thing certain that we have learned from the Affordable Health Care Act history thus far is that it has been in a state of flux, with changes being made in the requirements frequently in order to meet with the problems, both political and societal. What's going to happen to Frisbee Memorial Hospital and the others who are placed in the position of not being selected, forced to give up much of their client base, let members of their personal staff go, and then find more changes being made in the Act's requirements that would have made those things not necessary? The Commission, I believe, should hold this and other requirements in abeyance until they have a sure and reliable dictate to follow. Anthem, who has served the state honorably and well over the years, is forced to take orders from the federal government for affordable care to make it fall into Anthem's policy of retaining the information that went into the study of the Commission. The legislature and the New Hampshire citizens have no knowledge on the basis for the decisions that were made. This is an example of how a good system can be destroyed when politics and government oversteps their bounds and takes over its functions. In this case, one of the New Hampshire Congress members who voted for affordable care and supported it is quoted now as saying it's wrong, it's unfair, while accusing the state and the federal authorities are rubber stamping Anthem's claim of network adequacy. One must ask, isn't this an example of a tail wagging a dog on an issue as resounding as this? Shouldn't Anthem have reported the commission that represents all of the people in the state, who would then pass it on to the people for public hearings? What would happen if the federal government made a change that all food stamps had to be redeemed at a certain food chain? Well, I guess there'd be hell to pay then, wouldn't there? Same thing's happening with health care here and our providers. It has to be changed. I'm here to implore you to let Frisbee Hospital make their case to be able to function as part of the network based on their history built by them over some 72 years. Thank you so much.
Thank you, George. Very much appreciate your comments this morning. Thank you. Next is Bill Nelson from Carroll County District 5. Bill?
Thank you very much for allowing me to come here. I'll be very brief. What kind of explanation do we give to the 9 hospitals we have invested money, or to the people, I should say, who have invested in their 9 hospitals? How about the hospitals that invested in their communities by outreach programs? This is something about fairness. It's about monopolies. It's about jobs, about the patients that are inconvenienced by the extra travel and expense, about having to leave a hospital employed doctor they have been with for years, who they know and trust and who knows their medical history. About the residents of New Hampshire who will need to establish themselves with a new doctor. They hope the wait time will not be long. They hope the doctor will have time to review their complicated medical history. They hope this new doctor will be as good as the one they are forced to leave. Let's not forget the thousands and thousands who are not part of the exchange and may use one of those 9 hospitals. They could be covered by Medicare and Medicaid or have private insurance. Think of one of their doctors who may no longer be there. What are they going to do? The hospitals are in a jam because they have fewer and fewer patients. Are they going to let your doctor go? Then there's always the possibility they will cut an additional 5 hospitals. Could happen. They could save some money. What are you going to tell the folks when that happens? I know we've heard about 2 additional insurance groups coming on board, but what's going to happen with them? Do they get to choose the hospitals they want to serve? I really think this is an unfair situation, and all hospitals should be allowed to participate in the program. Thank you.
Thank you very much for your comments this morning, Bill. Appreciate them. Next is Fenton Groen, a Rochester resident.
Thank you, Mr. Commissioner and members of the Insurance Commission. I'm going to be speaking mostly on a personal side, although I have represented Rochester for a couple of years as Senator from District 6, Rochester and surrounding community. Been a Rochester resident for a little bit over 25 years. We have been served well by Frisbee, a small business owner in Rochester with employees in Rochester and in surrounding communities. 4 of our 7 children were born in Frisbee Hospital. Did an excellent job. None of them were so rushed that the distance of about 8 minutes was a real issue, but we were served very well there. I just want to address 3 important aspects of medical care and how it impacted us as a family. First of all, access. When my daughter Deborah was going into her junior year of school, we woke up one night and she was in intense pain, and we took her the normally 8 or 9 minutes to Frisbee was about 5 minutes to Frisbee. And as she was being prepared for surgery, her appendix burst. The care was phenomenal. She recovered. She was about a week in the hospital. She recovered, and 2 weeks later started running cross country at school. The extra minutes of going to another hospital in the area may have made a substantial difference in her outcome. The quality of service, and it was very much there with Deborah, but I want to relate that in the case of my son Joseph, my youngest son. Also late in the evening, he started experiencing very intense back pain. We took him into the emergency room, and the emergency room within a half hour accurately diagnosed him as having Wilms tumor, began doing the tests at the hospital, made arrangements at Boston Children's Hospital and Dana-Farber for him to be taken there by ambulance the next day. And before they even had seen the results of the ultrasound and the x-rays, accurately diagnosed him as having Wilms tumor. Timing, again, was important. The quality was there. They knew what they were doing. It's an excellent hospital. I just want to give you the end of the story of my son Joseph. That was about 32 years ago. He's now a nurse at Frisbee, and we're very appreciative of that. For myself, I'm going to relate it to the cost. I had a planned surgery there after a little construction accident that reconfigured my nose. I had to have surgery on my nose. And my wife and I and our family have been self-pay for about 18 years. And we're part of a national healthcare sharing plan. In the process of preparing for that surgery, we had time to prepare for it. I called 3 different hospitals and 2 standalone surgery clinics to check on pricing. Frisbee was the cheapest by over 30%. I had no hesitation going there because I already knew their quality. Again, excellent care and excellent results. So why would we exclude a hospital of this quality? Why would Anthem exclude them? Their claim is that they're saving 25%. Every time I've done cost comparisons, and while I was senator, I a number of times would call various healthcare providers in the area to check on comparative costs. Frisbee was always competitive. I don't understand the argument that they can save 25% by excluding Frisbee. I want to close by just referring you to Article 83 of the New Hampshire Constitution. Article 83 expressly forbids monopoly in the state of New Hampshire. It aligns the power of the legislature and of the state administration to prevent monopoly in New Hampshire. I think we are experiencing monopoly in New Hampshire, and I would urge you to really look hard at that. Thank you.
Thank you very much, Fenton. Really appreciate your comments this morning. Next, I'm going to ask Margaret McCarthy, a Frisbee patient, to come and speak, please.
Good morning. My name is Margaret McCarthy. I live in Rochester. I'm here today to voice my concern with Anthem's new narrow network and express my support for the inclusion of Frisbee Hospital and their associated providers. I've been seeing Frisbee doctors for over 15 years. They have provided dependable, efficient, convenient care. A few years ago, I required emergency surgery for a life-threatening condition. These doctors saved my life and cared for me during a long recovery. I like them. I trust them. I want to keep them. I am reassured by the fact that Frisbee's comprehensive computer system allows each of my doctors access to my complete medical history, including past procedures, current medications, and recent lab results. It doesn't make sense to me that I should have to drive past my local hospital and doctors to seek health care in another community. I am retired and pay for individual insurance coverage. It is expensive. Currently, I pay over $7,000 a year, plus a $2,500 deductible. It doesn't make sense that if I want to keep my doctors, I will have to pay 37% more because that insurance is not available on the new insurance exchange. That insurance is not eligible for subsidy. If I were to choose a plan on the insurance exchange, it would cost less, but it would only cover providers in Anthem's new narrow network. I would have to find a new internist, a new gynecologist, a new surgeon, even a new lab for my blood work. It doesn't make sense that Frisbee says it will accept the lower rates of the new network, but Anthem won't talk to them. In fact, Anthem has excluded 10 hospitals and their associated providers from their new network. It doesn't make sense that Anthem is excluding providers just at the time when more newly insured people will be seeking more health care. Common sense would dictate that any competent provider willing to accept the rates ought to be included in the network. I am concerned about the effect of this narrow network on my community. Will Rochester start losing doctors? Will Frisbee Hospital have to lay off employees? Will community health care services have to be cut back? And most importantly, will people delay or stop going to the doctor altogether because it is simply too difficult to get there? It doesn't seem fair that the new network will force people to travel further and wait longer for medical care in a state that has limited public transportation. An insurance company should facilitate getting health care, not make it more difficult. We depend on the insurance department to make sure insurance business is conducted in an open and fair manner. There have been 3 years to prepare for the Affordable Care Act. It doesn't seem fair that New Hampshire has only one insurance company offering plans on the insurance exchange. It doesn't seem fair that this new network was decided in secrecy and only made known to consumers a few short months ago. There has been talk about the adequacy of the new network, but it seems to me that common sense and fairness should be of greater concern than adequacy. I commend you for holding this meeting and allowing us to voice our opinions, but this is only the first step. There is much more work to be done to make healthcare in New Hampshire both affordable and accessible. Thank you.
Thank you very much, Margaret. Very insightful comments. Really appreciate them this morning. Next, I'd like to call on Denise Ambrose, a concerned individual.
Hello, ladies and gentlemen. I am Denise Ambrose. I'm here with Frisbee, and I am speaking on a more personal level. I just wanted to bring to your attention some caregiving that I did with my mother. My father had Alzheimer's. He was an engineer at a major business in Somersworth, and we went to a support group at Frisbee for quite a few years, and we took care of my father for 4 years. And one day he went for a walk. He got lost, and we were able to find him, and thank God we were. He had to get We had to call the ambulance, and he had to go to, hopefully, we thought, to a local hospital, but there was a quarantine at that hospital, and the geriatric ward could not accept him. We then went to a geriatric ward that accepted him an hour away. We had to travel. I had to take FMLA. My mother could not drive that far. She's comfortable with driving around town. We finally were able to get him into a ward and get him evaluated so he could go to a nursing home. My father has passed away, but I wanted to bring this to your attention. There's also an issue where a neighbor of mine, over 55 years I was this man's neighbor. He was at the Rochester Manor. He was dying, and minutes counted. He had to get transported to the ER at Frisbee, and Frisbee has always been wonderful to any of my family and friends. Because he was a few minutes away, we were lucky enough to spend time with him. If he had to travel any longer distance, he would have died on the ambulance. We would have never had those few minutes with him. My mother, for many years, I come from a family of 12, and I'm the oldest, and my mother had Dr. Smith at Frisbee. We loved Dr. Smith, and we loved Frisbee. They took good care of my mother and all 12 of us. So I followed suit. I had to have a C-section, but I couldn't have Dr. Smith. But I just wanted to bring some examples of how close and how minutes count for us as individuals. Thank you.
Thank you very much, Denise, for your comments this morning. Next, I would like to call on Mark Farrell from representing Frisbee in the Chamber of Commerce.
Thank you for allowing me to speak. On behalf of, Mark Farrell, the chairman of the board for the Rochester Chamber of Commerce. On behalf of the Greater Rochester Chamber of Commerce, representing approximately 450 businesses, we would like to express our concern with the Affordable Care Act and how it is impacting residents and the hospitals in our area through the Health Insurance Exchange of New Hampshire. When it was announced that Frisbee had been excluded from the Health Insurance Exchange in New Hampshire under the Affordable Care Act, patients with no insurance are required to join the Health Insurance Exchange, as we all know. Anthem Blue Cross Shield is the only carrier that joined the marketplace in New Hampshire. We all know that. As a result, patients with individual health plans under the Affordable Care Act will not be afforded coverage at Frisbee Memorial Hospital and other hospitals throughout New Hampshire that were excluded from the Health Insurance Exchange unless it is for emergency care only. Frisbee Hospital is a regional hospital offering medical services to thousands of residents throughout Stratford and Carroll counties, and provides several physician facilities to accommodate the medical needs of patients in all these areas, which some of them are quite rural. These patients will now have to travel much further to see doctors at other hospitals that are being included in the Health Insurance Exchange. We understand that everyone is trying to minimize cost. We believe that this type of exclusion is not the answer. It is extremely unfair. It provides a disservice to our hospital, our physicians, and certainly to the patients who will now be forced to change their medical providers. This goes against what we were all told the Affordable Care Act was going to do, such as providing competition and allowing patients to keep their doctors. We urge you, on behalf of the Chamber of Commerce, to find another method that does not exclude our dedicated hospitals from providing quality health care to the patients and allow the citizens the freedom to maintain their health care providers. Thank you for allowing me to speak.
Mark, thank you very much for your comments. I do appreciate them. I was going to say this morning again, but it's now this afternoon. So your comments this afternoon. Thank you. Next is Dr. James Betty, a physician.
Mr. Commissioner, thank you for the opportunity. We've communicated a little bit in the past. I'm a urologic surgeon. I work out of Rochester and Portsmouth. Both of the hospitals were not included in the narrow network. In December, I emergently operated on a patient, stabilized her, and when she got out of the hospital, I said to her, "You don't have insurance. You should do something about that. Go to the Affordable Care Act." So in early January, she came into the office, and I said, "Well, I'm glad you have the insurance, but even though I know you better than anybody else and probably could do this better, take care of the final problem, you got to go somewhere else." She couldn't believe it, but that was the reality. I've had multiple patients that have lost their insurance, and they told me, "I'm sorry, I have to sign up for the Affordable Care Act. I can't see you anymore." You see, the elephant in the room, and why the people are really mad, is they were promised by the President of the United States and our United States senators that this would not happen. They were told that they could keep their health care insurance, and they were told that they can keep their hospital and doctor, and it has not happened. And they're mad. Then they should be mad, because there's a public trust that's been violated. And I'll tell you quite frankly, they don't believe that you're going to do anything about this. When you talk with them, they say, they'll just do what they're told. Your mission statement, and I'm going to read it to you. The mission of the New Hampshire Insurance Department is to promote and protect the public good by ensuring the existence of a safe and competitive insurance marketplace through the development and enforcement of insurance laws. You are committed to doing so in an honest, effective, and timely manner. I really appreciate what I learned today about the process, but what we're talking about is the Affordability Care Act. We're talking about an insurance that's being forced upon people. Otherwise, they get a fine. There's no competition. They don't have a choice. There is no competition. Now, I've been on the Seacoast. I went to Dartmouth. I've been here 27 years now. I know the Seacoast as good or better than anybody else. The network that was picked on the Seacoast, which is Exeter Hospital and Wentworth Douglas Hospital, it's geographically not the best network. It doesn't provide essential services, and they are, without question, more expensive than Frisbee Hospital. So the argument being made earlier that access equals less cost is not true. Actually, competition decreases cost. And we can talk about what happened in New Hampshire and why it's so expensive at another time, but it has nothing to do with what you said. So the question is, what are we going to do about it? And it turns out that you're the only people that can do something about it. And it was very enlightening to see that you do have an opportunity to change the rules. It seems like that process isn't all that hard to do. It seems like that we ought to have full exposure. We ought to have transparency. We ought to know what happened behind closed doors. We ought to know why Blue Cross Blue Shield can make a contract and we don't know why they made it. We're paying for it. This isn't some non-competitive, this isn't some private product. that people can choose or not. They're forced to take it. And you guys need to step up. I mean, you had 3 years, 4 years, whatever, 3 years. This shouldn't have been a big surprise. So, as one more example and I'll be done. Right now, neurosurgery and cardiac surgery, essential services are at Portsmouth Hospital. Portsmouth Hospital is not included in the network. So if you get a primary care doctor, you live in Hampton, you're going to drive up to Dover, and if you have a little bit of a problem and they put you in the hospital and you need cardiac surgery, they're going to put you in an ambulance and send you to Boston, driving right by Portsmouth Hospital. Now, if you just sort of don't quite make it, it's about $30,000 that will go in, instead of being spent, will be available for the $25 million bonus that the CEO of Blue Cross Blue Shield got. So I think it's time to step up. Frisbee clearly is a high-quality hospital, so is Portsmouth. And if you were ever to allow them to close, that's what will happen. The Blue Cross Blue Shield representative said in the paper, well, you know, we got to close some of these hospitals in New Hampshire. I'm not sure that's their call. Thank you very much.
Thank you very much, Dr. Betty. Appreciate your comments this afternoon. Next, I'd like to call on Patrick Carroll from Congressman Shea Porter's office.
Hello, thank you for having us today. We appreciate this very much, to the department, the commissioner, and to everyone that attended today. It's also very nice to put some faces to many of the people I've spoken to over the phone over the past few months. I have a letter from the Congresswoman. I regret that I cannot attend today, as I have work in Washington, but I appreciate the chance to express my opinion about Anthem's narrow network. I have been challenging Anthem's narrow network ever since its details were announced. I believe that Anthem's decision to offer a narrow network is wrong, especially since this year it has a monopoly in the marketplace. While next year it will have competition, Anthem should not have had a monopoly. Second, it should not have left out of its network those hospitals and doctors who wanted to participate and were willing to accept its rates. Third, Anthem never should have tried to push individuals who have already had their own individual policies into that narrow network, especially since no study has been done on capacity. Luckily, Anthem backed away from that plan and did allow those folks with individual policies to keep their doctors and hospitals in 2014, so that problem has been averted. However, the newly insured, those who had no insurance until they signed up under the new healthcare law, have been directed to a much narrower network than those who have employer-based insurance or renewed their Anthem policies by December 15th. While the newly insured is a much smaller group of affected people, it is still outrageous that some of them will be forced to drive further for care, leaving out doctors and hospitals that may be closer to them. For example, a newly insured woman in the Ossipee area who needs prenatal care now, and the relief and happiness of finally having a health insurance is tempered by a longer drive to a hospital and doctor. She has to drive right by excellent doctors and an excellent hospital in Rochester, Frisbee, to go to Wentworth Douglas Hospital. Wentworth Douglas is an excellent hospital, and so are the doctors there, but it makes no sense to force a patient to drive longer distances for medical care that we do not know if there is a capacity. I have made these points repeatedly with Anthem, with the Centers for Medicare and Medicaid Services, and with the United States Department of Health and Human Services and the administration. The federal government should have required a market conduct exam before they approved Anthem's proposal. The federal government announced this week that instead of rubber stamping ACA marketplace networks like it did this year in New Hampshire, it will next year require insurers like Anthem to provide comprehensive lists of healthcare providers in their networks, and it will actively evaluate whether they provide reasonable access to hospitals, primary care doctors, and other essential services. While I'm happy about this change, this should not have been the policy from the beginning. The public deserves information about whether the network is too narrow and lacks capacity. I am pleased that the New Hampshire Insurance Department recently ordered Anthem to do a market conduct exam, so we would finally have some answers. Doctors and hospitals who are impacted deserve to have a say on the effect Anthem's plan has had on them. That's why I'm so disappointed that we do not have all that information today. Frisbee's Hospital's Chief Executive Officer, Al Felgar, and I jointly called on Anthem to allow the release of the results of the market conduct exam so we would have all the results at this hearing. Unfortunately, Anthem chose not to do so, so the public in this room does not have the results that they need. Although the current situation is unacceptable, we will not find ourselves in this predicament in the future. We know that historically, New Hampshire consumers have had few insurance choices. For years, only a few insurance companies dominated most of the market in New Hampshire. While Minuteman Health is approved to expand into New Hampshire and form a new health insurance co-op, we also expect Harvard Pilgrim to offer plans in the marketplace next year. All of this is great news, but I believe Anthem, because of its monopoly this year, should widen its network now. I have seen the dedication of so many health professionals, community advocates, elected officials, and others in the federal government and state government who are working together on behalf of the citizens of New Hampshire. I am glad that state legislators are working to craft new adequacy regulations, but it is my hope that Anthem will open its network to make our health care law work better for the newly insured right now. Thank you, Carol Shea Porter.
Thank you very much, Patrick. Appreciate your comments this afternoon. Next, I'd like to ask Marianne Aldrich from Cottage Hospital in Woodsville, New Hampshire. Marianne?
Good morning. Thank you for hearing us. My name is Marianne Aldrich. I'm the Community Relations Director for Cottage Hospital. I'm here today to represent not only our hospital, our internal medicine department, but also the community in which we serve. Cottage Hospital is located in Woodsville, New Hampshire. We're a critical access hospital, and we've been servicing our community for 110 years. Like many of the other hospitals, we too were not included in the network. My biggest concern today, is very similar to what everyone in this room has said. We've heard the same anecdotal, comments and so forth, but it struck me as I was sitting there, I just finished completing our 2013 Community Health Needs Assessment. Now, this is part of the Affordable Care Act, as well as a regulation set forth by the New Hampshire Department of Charitable Trust. So by completing this, I'm meeting part of our ACA requirement, and part of that is also an implementation plan. We recognize what our community needs, and what are we going to do to fix it? We're mandated by the ACA guidelines to do that. So what do I recognize? Access to primary care, mental health, diabetes education, and transportation barriers, to name a few. But the problem is by being cut out of this network, we can't fix these things. We can't work with our collaborative partners to be able to work on these things because we've been cut out of that process. Furthermore, I guess a point of clarification a little bit to what you had said, Tyler, and what a few people have mentioned here today. The concern with network adequacy and the free market, I think our senior team certainly understands the need to be able to put the insurance company and leadership in the same room. But like it has been stated, we weren't even asked to sit in that room. So for someone who is in need of urgent care to not be able to access primary care, where does that then put them? Into an emergency department. And we all know that the costs within an emergency department certainly are going to increase the cost of health care. So I just struggle a little bit with understanding where the savings, like we've all said here this morning, come from. We were more than happy to discuss what the reimbursement was going to be and want to be able to provide care for our community through primary care, not our emergency department. Thank you.
Thank you very much, Marianne, for your comments this afternoon. Appreciate them. Next, I'd like to call on Lisa Stanley, a Rochester employer. Lisa?
Thank you very much. Thank you for the opportunity to take part in this hearing. I've heard a lot of discussion about the individual aspect of the ACA, and it struck me recently when I found out a local state legislator did not realize that small businesses have been affected under ACA and Anthem's narrow network as well. Since the Affordable Care Act became law in 2010, as a small business owner who has always provided health insurance to my employees, I've been able to take advantage of a tax credit on my federal taxes. The credit has offset the cost of providing insurance to my employees by several $1,000s each year and has enabled my company to continue to pay 95% of premiums on behalf of our employees. I became aware that the credit would only be available for tax year 2014 if I purchased my employees' insurance through the federal exchange in New Hampshire that is called the SHOP. And as you know, Anthem is the only carrier offering plans through the SHOP, and those plans utilize this narrow network, which excludes my primary care doctor and my local hospital. I'm not alone in my workplace, as 3 of our 5 employees are similarly affected. After obtaining quotes from Anthem under the SHOP and from my existing insurer, which was Harvard, I was forced to make the strictly financial decision to select a plan through the SHOP, which was the most affordable based on premium coverage and my continued ability to take advantage of that tax credit. I figured that we would all bite the bullet for a year, get new doctors, in hopes that next year there'd be more competition within the SHOP. Now I'm going to share with you my personal catastrophe. And I know this is a public hearing, but those of you in the room that know me personally, as many of you do, please keep this to yourself. On December 20th, the week before Christmas, and after we had already applied for the coverage under the SHOP, I found out that I had had a suspicious mammogram, and I was required to have follow-up. I had that follow-up and was told that I needed to go see a surgeon and have biopsies done on both breasts. I no longer have a PCP. I no longer have an OBGYN. I spent 2 hours on the phone, on hold, waiting for Anthem to take my call the other day, and I don't know whose world that's customer service, but apparently it's theirs, to find out if, given my particular situation, I would still be required to get a referral to go see a surgeon. Yes, indeed, I am. I'm paying 100% out of pocket because it's subject to my deductible, but I have to find a primary care physician now and get a referral to go see the surgeon I need to see, based on information I had at the end of December. I never received my insurance card until the last week of January. I heard, actually the first time I've heard it referred to, I heard something about continuity of care in this room today. And I hope that the committee considers that. I hope that your office considers that, and I hope that changes can still be made, because I would sure appreciate some continuity of care in my personal situation. I appreciate that you explained how the rules and a detailed description of the rules and how the department has in place network adequacy guidelines and all of that. But in addition to the rules, you also publish a mission statement on your website. And it reads, "The mission of the New Hampshire Insurance Department is to promote and protect the public good by ensuring the existence of a safe and competitive insurance marketplace through the development and enforcement of insurance laws in the state of New Hampshire. We are committed to doing so in an honest and effective and a timely manner." Point 1, limiting our options to one provider under the SHOP plans is not a competitive marketplace. Point 2, the narrow network that has been allowed to employ, that Anthem has been allowed to employ, does not promote and protect the public, because we, the public, are being denied access to our doctors. And frankly, I believe Frisbee to be a superior hospital than those offered under the plan. Point 3, you've not fulfilled your mission to do so in an honest, effective, and timely manner, because my understanding is that all these agreements with Anthem were done under not the light of day, but the dark of night. That not only was the public not aware that we would have limited access to our PCPs and our hospitals, but the hospitals that are willing to provide the same care at the same price were also not aware. So I don't know if anything can be done at this late date. I implore you to please consider doing something, and I appreciate your time.
Thank you very much, Lisa, for your comments this afternoon. Next, I'm going to ask Peter Wright from Valley Regional Healthcare to speak to us.
Good afternoon. Thank you for the opportunity to speak to you today, and I appreciate your service to the state of New Hampshire. I have some good news and some bad news. I'll give you the good news first. I'm not going to read you your mission again. The bad news is that map. That map represents an adjustment from the original plan. The original plan did not have Littleton Hospital and AVH. That map represents green dots and red dots. The green dots are where the money was. The red dots are the places to stay away from. The insurance model is pretty simple. You collect premiums, that's money coming in. You try to limit the expenses, the balance is profit. We all know that Anthem is a for-profit provider. So part of me, small part, doesn't blame them for putting together the network that they did. They lived by the rule of law, okay? Little part. I still think we have a duty to serve the people of New Hampshire, and I include Anthem in that. The bad news is the department saw the map. I asked them about the map in September or October, I think it was, at the Hospital Association. And the response I got was, they met the letter of the law. What could we do? What we expected you to do was to perhaps approve it because they met the letter of the law, but speak out about it. Now, the good news is I believe that everybody in this room and the people of the state of New Hampshire have forgiveness, and they can get beyond the fact that the plan got through without any negative comment from the administration or the department, a Friday afternoon press release. Because I believe that through everybody in the room and everything that's being done so far, you will take the opportunity to look at the rules and make changes. We cannot have a system where an insurer, regardless if there's one or if there's five, can put together a network like that, where they exclude the people of the North Country, where they exclude the people, is that my cue? Where they exclude the people of Sullivan County, the two most economically disparaged communities in the state. I'm not here to talk about Valley Regional, okay? It's not your job to make sure that Valley Regional stays afloat. But I would remind you that all the hospitals that have excluded from the network provide free assistance, support. The Senator mentioned earlier about the expense of health care in the state of New Hampshire. One of the main driving reasons is we rank 51st in the country for Medicaid reimbursement. 51st. Okay? We actually have one of the highest quality systems in the country. There are folks from the Institute for Healthcare Improvement who come to New Hampshire to learn how we're providing care so that they can share those best practices throughout the rest of the country. The Hospital Association has a lot of information about the Partnership for Patients. Okay? We have some of the greatest thought leaders in the nation, in the world, right here in New Hampshire, trying to drive new models. We've provided care for these patients year in and year out. In Sullivan County, the uncompensated rate for care is about 11.4%. Okay? We have an obligation to the people of New Hampshire. I will end my testimony today the way I started last week in another hearing, with a quote from one of my favorite people, Forrest Gump. I'm not a smart man, but I know what doing the right thing is. This is not doing the right thing. I have faith in you that you will do the right thing. Thank you very much.
Thank you very much, Peter. Really appreciate your comments this afternoon. Thank you. Next, I'd like to ask Emily Blatt from Southern New Hampshire Medical Center to speak. Is Emily Blatt here? No. We'll reach out to her then and get whatever comments she may have had to leave. Next, I'd like to ask George Kurt from the Insurance Center to speak, please. We'll do the same with George. We'll reach out to him and ask him to provide us with his written comments. Next, if I could have Steve Hayden from Core Benefits Group speak to us. Steve?
Well, thank you for presenting the opportunity for people to speak. Core Benefits Group, we are the largest agency for Blue Cross Blue Shield, an individual. We have been for the last several years, so we really feel this pain. We're stuck in the middle. Core also operates in over 30 other states. And I'll tell you right now that New Hampshire, by far, is the most challenging state to work in because we have that one and one only, provider here. I can tell you about personal stuff. I'm not just an insurance agent. I'm a business owner. I have employees. I have a small property management company. I own some commercial properties. I hired a friend of mine who was, he retired from the union. He's still in his 50s. His health insurance with Anthem is almost $30,000 a year. His salary is $40,000 a year. And I pick those benefits up. And I'm not blaming Anthem. Anthem is the cheapest company out there. If I went to companies like Harvard Pilgrim, it was going to be in the mid-30s to provide health insurance. And this is I think we have a $3,000 deductible right now. That's scary. So the problem is not Anthem per se. I think the problem is we have no competition. What is wrong with this state that creates an environment where insurers don't want to come here? It's very unusual. Anthem is trying to keep their costs down. I don't agree with particularly what they did. There was nobody more horrified when they came to our office and said we're offering a limited network. Limited networks are not a bad thing. If you go into Massachusetts, almost all of the large HMOs, like Tufts and Fallon, they all offer a limited network program, but they also offer a full network program, and I think that's what Anthem should have done. I think, Tyler, you made a very, very good point when you were on your presentation. Give people a choice and let them choose. I want to share something with you because we do an awful lot of business here in New England. And I'll share with you something that's going on in Maine, because Anthem has done the exact same thing in Maine. But one additional provider came into Maine, a startup that started January 1st. Okay? And they are, I'll be honest with you, we have about 45 representatives in Maine working. And this other provider outsells Anthem probably 50 to 75 to 1 because of one particular reason. Why would somebody pick a no-name company that has never even paid a claim yet over Anthem Blue Cross Blue Shield? One reason: they have a network. And I find it very, very odd, and not realizing there were going to be so many hospital people here. But let me tell you something very interesting. The people in Maine can come to New Hampshire, use Frisbee, because I checked, use Frisbee Hospital, being subsidized by the government to use New Hampshire hospitals, New Hampshire doctors. That network covers almost every single hospital here in New Hampshire, almost every single doctor in New Hampshire, almost every single clinic in New Hampshire. The people in Maine can come to New Hampshire and use all of that, being subsidized by the government, and the person that lives across the street from the Frisbee Hospital can't use it. And I am not blaming Anthem. The issue is we have no competition. How do we get competition in the state? Don't blame Anthem, because we want to talk about profits. They're limited, and I know the department knows that. They have an 80% loss ratio. They have to pay out 80% of every dollar they take in claims. If they fall short, they send you back the money. Okay, so I don't want to blame Anthem, because they're doing, I think, what they believe is the right thing. I don't want to blame anybody. We just have a system here that's not allowing competition to come here. Why don't we have Aetna in here offering individual programs? Why don't we have United here offering individual programs? Why don't we have Humana in here offering individual programs? There's something wrong. You know, and I think our legislator, I think it's more designed for them. They need to look at this. Why are we so expensive? We are, you know, someone brought up we were the second highest rates in the country. We are also, year after year after year, in the top 5 healthiest states in the country. So, again, something is wrong. Why don't carriers want to come here? All we need is one. I just wish that we had, you know, a Maine Community Health Options that decided to, let's step up and jump in. They were subsidized by the government to go into the state. How do they offer a program that is so comprehensive? And by the way, their rates are almost identical to Anthem's in Maine, yet they offer the entire network. She's holding up to zero. I mean, zero. I'm sorry. I thought I was only talking for a minute. But thank you for your time. And I just really wish we could address the, you know, the competition. That'll fix everything. Thank you.
Thank you very much, Steve. I really appreciate your comments this afternoon. Next, I would like to ask Casey Crane to come and speak to us, please. Casey?
Yes, I am former Representative Casey Crane. I also had an organization called The Patient Speaks at one time that helped out with the hepatitis C as a one-year project, helped out with the hepatitis C effort to get a clinical trial established. I am here to read a statement from former Senator Joe Kenney. He is in Colebrook right now. Over my 14 years in the legislature and as a former state senator from District 3, which spans from just north of Rochester to Conway, I have seen many, many situations where having local care has made the difference between life and death. And with many small businesses and others now being forced into the exchange due to the Affordable Health Care Act, we will see a growing number of these people who will now have to find care far away from their local hospital. The Insurance Commission is put here to protect our citizens, not to ration health care. I am also very concerned about Sullivan County and North Country. I am currently in Colebrook right now attending a Helping Hands meeting. It is totally unacceptable that the citizens in Sullivan County are being told to drive outside their county. As someone who has served his country in 3 war zones, I never thought I would see this in my America. The adequacy rules are inadequate to serve the needs of our citizens. To take further action on this issue, we need a public forum on the loss of our hospitals. We need to videotape all the patient stories here and send them to Washington. I'm inviting the current insurance commissioners here, the hospital administrators, and all of the patients present here to such a forum on Thursday, February 27th at 10 a.m. at the Claremont Common Man. Their voices must be heard. I hope in District 1 to be a source of public policy which is good for our citizens, and to use politics to bring important issues forward for our citizens. The loss of New Hampshire hospitals is an extremely important issue to my citizens, and therefore it's important to me. And I would just like to comment personally, as a former state representative myself, that a comment was made earlier that if you needed a lung transplant in North Country, you would be comfortable coming down here. Unfortunately, from what I have seen, and I have traveled quite extensively throughout North Country recently, it's not a choice for these people. They don't have the money. They don't have the money. Their friends don't have the money. Their family doesn't have the money to pay the gas. Do you have any idea how much you spend in gas driving around? It's insane. You have to drive so far that your family can't be with you, your friends can't be with you. To make it an even greater hardship on these people, to me, is incomprehensible. Thank you.
Thank you very much, Casey. Really appreciate your comments. Next, I would like to ask Thomas Jean, the mayor of the city of Rochester, to come up and speak with us.
Well, thank you very much, Commissioner Savini and members of the Insurance Department. I greatly appreciate your time, and as an elected official, I can appreciate what it's like sitting up there and listening to everyone express their opinion, and I thank you for your time this morning. And you can add me to the list that pulled up the mission statement, so I won't read that again in the interest of time. But I think it's important to realize that the City of Rochester is very concerned at what's going on with the exclusion of Frisbee Memorial Hospital from the Pathway Network. And I think that there's a lot at stake here, not only for the hospital, but for the City of Rochester. As Frisbee Memorial Hospital is one of our largest employers, provides a lot of community benefit in terms of quality health care and community health services. This would be a tremendous loss to the community if Frisbee was no longer able to remain sustainable by virtue of the decision of the Anthem Pathway Network. Going back to the mission statement real briefly, I think the reason we're all bringing it up is mission statements are meant to hold all of us accountable. And I think that's what the people in this room are looking to do with the mission statement today, is to hold the insurance department accountable for the decisions that's been made. And really, in retrospect, this conversation probably should have occurred in June, July, somewhere where we could have had a say in your decision to allow the Pathway Network to enter into existence. And I think because federal funds were being used, we all had a say at that point. And that's the frustration that I'm hearing from my constituents in Rochester, is that they are being forced to sever their longstanding relationship with their primary care physicians, their specialists. I mean, there's no better relationship than that of a patient and their oncologist, for example. And those relationships are now being jeopardized, and it's very difficult as an elected official to hear our citizens in such pain and in such despair. So rather than go with my talking points, which have already been hit upon earlier, I just implore you to really look at this closely. You do have an option. This was thrusted on you, I think unfairly, that the department has been placed in this position, but equally, you can thrust this back on Anthem, and you can make a decision amongst yourself to say, please engage Frisbee Hospital and the other excluded network providers in coming up with a solution that's a New Hampshire-based solution, something that's going to take care of our entire population. And I hate to call on you, Mr. Brandon, again, but you spoke very eloquently in your presentation, and you spoke about access, and you spoke about negotiations. Well, to my understanding, there was no negotiation at all with Frisbee Memorial Hospital. That right there, when there's a program using federal funds, is just really unacceptable. So I urge all of you to really put some pressure back on Anthem, force them to the table, or at least request them to the table, and then the pressure will be off all of you. So thank you for your time this morning, and I certainly appreciate the hard work that you do.
Thank you very much, Thomas. Really appreciate your comments, and it's this afternoon. Thank you. Next, I would like to ask Alex Ash, a family doctor from Somersworth, to come and speak with us, please.
Thank you for having us. In the sake of being brief, many people have touched on many of my points, but I wanted to say I've been a family doctor in Somersworth, New Hampshire for 10 years. I know many of these patients who we're talking about, and many are leaving, and I understand what motivates them, and this is a challenge financially for them to have medical care. This is a shift change for these patients. A lot of them will be going from one physician to another, and we've already heard a woman in the room saying that she may not be able to get a referral for breast cancer care. A lot of mistakes happen during shift changes, and this year will be a shift change. But my emphasis today that we haven't touched on as much is preventative care. And I want to say that I think that when you're working with a population that is the working poor and the middle class, a lot of them will take this insurance as an option or be forced to take it. And my opinion is that I don't think they'll be able to that they will show up for a lot of their preventative appointments for diabetic care, for high blood pressure, prenatal care. I think this will force them into making a decision of, do I have enough money to afford to take time away from my work, or will I have to pay for gas? And I think a lot of them will choose to put off preventative care for the sake of working and maintaining their finances until they use this insurance as catastrophic care. And I don't know if that was the original intent, but I suspect that that's what this will be. So I think that while we all agree and have discussed that that this was legally acceptable, I don't think that this functional monopoly is morally acceptable. Thank you.
Thank you very much, Dr. Ash. Appreciate your comments this afternoon. That brings us to the close of the speakers, and we're going to go to the Q&A. I've got a number of question cards that were submitted to us, and then Anthem will finish up with their presentation. Frisbee will provide their presentation. Thank you. I'll take the questions in the order that they were given to me, and start with the one. Actually, I'll combine them because they very much touch on exactly the same thing. What does the insurance department consider to be the roadblocks to competition? And I'm assuming that means insurer competition. And so the follow-on is there some way your agency can prevent there ever being only one carrier available, a monopoly? Can you revise your criteria in order to protect the rights of individuals in this state? And I'll take a stab at answering that question first. Probably the biggest stumbling block to increased competition is the fact it's multifold, really. First of all, we're a small state, and we don't attract a lot of insurance carriers coming to the state in the health insurance arena. Secondly, the cost of care in New Hampshire is very, very high. It's in the top high percentage in the U.S. And you heard, I think it was Mr. Hayden talk about the fact that cost of care is directly related to what premium charges are and what consumers are expected to pay for the cost of their health care. Network development is not an easy task. And if you ask the carriers, not just Anthem, but all of the carriers that either are doing business in the state of New Hampshire or are looking to do business in the state of New Hampshire, development of a competitive network is very expensive. We have some ideas at the insurance department how the legislature could address some of these things, and we've talked to some legislators about how that might happen. But right now, volume brings the price to where carriers are able to negotiate. Having said all of that, the good news is that we've got at least 2 and possibly more carriers that have expressed an interest, a sincere interest, in doing business in the individual market in New Hampshire next year, in addition to Anthem. The first is Harvard Pilgrim. They've told us, and they've said it publicly, that they intend to put a product on the market that would provide individual coverage on the exchange. And the second is Minuteman. Minuteman is the co-op that was started in Massachusetts, providing the health insurance coverage in Massachusetts. They've gotten a federal grant to be able to expand their operation to New Hampshire. They're working with us right now in completing all of the applications that need to be completed in order for us to take a look at them first and foremost from a financial standpoint. So somebody said something about paying claims. That's our first responsibility. When we talk about a safe market and a safe marketplace and doing things for the consumer, the biggest responsibility I have is to make sure that the insurance companies you're doing business with, all of us are doing business with, not just health insurance, but all insurance, is sound and safe and able to pay claims into the future. Does anyone else have anything on my panel here about competition in the marketplace?
you're going to have to.
I would just add to the comment about the cost of network development and Roger's comment about the largest insurance companies tend to get the deepest discounts with our healthcare providers. That means an Anthem can go into a negotiation with an awful lot of leverage and say, we're half of your commercially insured patients. If you don't accept our offer, we'll steer it to another healthcare provider. That represents so much power in the negotiation that a smaller company coming into the state, even a large national giant like Aetna or United, doesn't bring the same amount of power as an Anthem does. And the insurance department has done 2 studies on this, and we showed several years ago that Anthem had essentially the deepest discounts among our healthcare providers. Cigna, Harvard Pilgrim, they had reasonably competitive discounts in certain areas, but they were still behind by a few percentage points. The smaller carriers, not competitive at all. So for a company to come into the state and try and establish a network at rates that are competitive with an Anthem, it has been extremely difficult. We did update the study a couple of years later, and we did see some changes in the relative carrier competition, but not to the extent that the small companies really had the same kind of discounts with healthcare providers that an Anthem or Cigna or Harvard Pilgrim did.
Great, thank you, Tyler. Those are really very good points. The next question is how many New Hampshire residents or citizens have enrolled in the ACA? And the numbers we have are 11,446 through January of this year on the commercial side. The next question, there is a difference between care and coverage. Anthem's decision creates an artificial shortage and can do so because there is no real definition of reasonable or wait time. What can the New Hampshire Insurance Agency, I believe they mean the department, do to strengthen the language of what is reasonable? Otherwise, I see Anthem exploiting this loophole to consolidate its dominance. Well, I think what I opened up this public hearing by saying, the fact that it's our intent to look very closely at the rules that regulate network adequacy and to put together in very short order a working group that would help us think through what the appropriate rules should be in New Hampshire for network adequacy. And I would certainly say to you that attempting to flesh out the word reasonable a little bit better would be high on the list of things that this particular working group would be looking at. So I do think that, but again, the insurance department regulates insurance. The insurance department does not write the laws, does not vote rules in. That's the legislature. We work very closely with the legislature and legislators and believe that we can continue to work with them at developing rules that will better address the needs of the citizens of the state of New Hampshire. The next question is, what is an appropriate distance for a woman in labor to drive to access care? You know, I can only speak from the experience that I saw my wife have 3 different times. I could never tell you what I think is reasonable time, but hopefully somebody on our working group can help us better define what is a reasonable or appropriate distance, not only for this particular sort of procedure, but for other things that people get treated for. Pardon me?
I just wanted to clarify, for emergency services, the narrow network is not relevant. You can go to any hospital or healthcare provider in an emergency situation.
That's true. I forgot that, Tyler. Thank you very much for clarifying that. A woman in labor, I believe, would be considered an emergency situation and would be covered regardless of whether the hospital or the facility was in the network or not. And that goes for any emergency service. Next question is, how do you assess the costs associated with mandating change of primary care physicians? How do you envision changing the rules to account for these costs and quality? The first part of that question, how do we assess the costs associated? That's best answered by those that pay the claims. I don't believe anyway that it would be up to us to take a look at or to try to assess the costs of mandating change of primary care physicians. I believe those that develop the networks and those that negotiate, and again, I'll ask Tyler once again, because Tyler, having been on the side that negotiated rates with providers, can probably bring better clarity, or maybe Jenny can.
Well, I wanted to say we heard a lot today about continuity of care, and we heard some really interesting and thought-provoking comments around that. So I do think that that's the type of thing that we would want to look at in looking at what the standards ought to be.
Well, I would first disclose it's been about 15 years since I was negotiating those contracts, but I would suggest that it is not considered as much as we'd like to think it is. I think there's an overemphasis on essentially unit costs and to an extent kind of overall programs, whether or not they're the medical home, disease management, utilization management, those types of controls when you look at healthcare costs. I think to the extent that there is a cost inherent with patients transferring between different healthcare providers, I think at this time that's been pretty understated. One of the unique things about New Hampshire, and it was alluded to in some of the testimony, is that we've essentially had all the healthcare providers in our insurer networks. That's very unusual compared to other states in the country. And the fact we have really high premiums and really good access to our healthcare providers may not be independent factors. So to the extent we're now moving into an area where we do have a narrow network, we do have people potentially changing providers based on those networks, I think that's a cost that hasn't really been considered in New Hampshire, not very well yet anyway.
That's the extent of the questions that we've had. I would now like to turn it over to either you, Al, or Jeremy, or somebody that's going to give us the Frisbee presentation.
So while the PowerPoint presentation is being put up, and I appreciate the department's assistance on that, I'd like to thank the department for the opportunity to speak today. As I said, my name is Jeremy Eggleton. I represent Frisbee Memorial Hospital with the law firm of Orr and Reno. And I'm here to talk, kind of to summarize a lot of the comments that I heard today. I'm kind of knitting together some of the anecdotal testimony, some of the more formal testimony, and trying to present what we believe to be a real problem with this network as it's been constructed. So I'm going to talk about the standards, just to recap. I'm going to talk about how they haven't been met, and I'm going to talk about what the result is for coverage here in New Hampshire. We believe that the department failed to apply New Hampshire law when it reviewed Anthem's marketplace plans in the summer of 2013. Because Anthem's plans and submissions were lacking data, and the substance of the plans was inadequate to meet the standards, the reasonable needs of the New Hampshire population, they never should have been approved. The result is a network of facilities and affiliated providers that omit some of the poorest parts of New Hampshire, placing a heavy burden on those patients to access care. So what went wrong? Again, we heard a little bit about this. Turning to slide 1, please. Go back to that previous one. You're looking right here on the screen at the total of the public communication emerging from the department concerning this process. On the left is a request for proposals issued to the insurance community in April 10th of last year, and on the right is a press release issued August 1st stating that the process has concluded, the plans have been approved by the insurance commissioner and submitted to the feds for final inclusion on the exchange. There were no hearings, there was no publication of applications, there was essentially no window into the process at all. And that was wrong. In circumstances where tens of thousands of New Hampshire citizens, I think 11,000 at this point, but surely it's going to rise later, are required to buy health insurance, and there was only one provider on the network, the department had a special burden to ensure that this network was adequate. Had the department actually required Anthem to submit all of the necessary information, the analysis would have shown that it didn't meet network adequacy standards. Slide 2, please. As we've noted, this is the language from the federal regulation. It's similar to the language in the state. It requires that services be accessible without unreasonable delay. Slide 3, please. The legislature here in New Hampshire did not want the federal government overtaking New Hampshire health insurance policy or health care policy. And so it gave the department the power and the obligation to compel Anthem to be accountable by ensuring that Anthem's network or the network of any provider was accessible without unreasonable delay. Now, to do that, as Mr. Feldwebel described, the department turned to New Hampshire's existing managed care framework. Slide 3, please. The next slide. I'm sorry, back one, yeah. Turning to this existing regulatory framework makes sense in some ways because it deals with narrow networks. But at the same time, we have to point out that the existing managed care framework was set up to deal with a market in which you have multiple insurance providers, each proposing their own managed care plans. So you have a competitive environment in which these managed care plans were intended to be selected by different consumers. This is not what's happening in the ACA. Not only do consumers not have the option of opting out, they have to purchase health insurance. And when you have what is now only one insurance provider on the network, that means they have to select from only one network as opposed to multiple networks. So to the extent that these regulations existed, that's fine, but they weren't necessarily intended to address the particular needs created by the Affordable Care Act. So it was worth reviewing them very carefully, and we don't believe that that occurred in this case. As you can see from 2701.04b in this case, a network is not adequate if it does not meet all of the standards enunciated in 2701.02 through .09. And I'm going to take you through some of those standards in order to show you how it is not adequate. Next slide, please. This is the big one that people have been talking about. Geographic access standards are stated in this regulation, and there are two subparagraphs here that I think are each very important. The key under B1 there, the blue language that I highlighted, are the words open and panel. What that means outside the healthcare industry is that these are providers who are taking in new patients, okay? So you need to provide at least two providers accepting new patients within 15 miles or 40 minutes of 90% of the population. The next point, part 2 there, is that the insurance company has to verify by submission of a consumer survey that the primary care provider network is offering a level of service that meets the member's needs. Now, flipping to the next slide, please. In each of these cases, Anthem failed to submit data. If you look carefully at the list of providers provided by Anthem to the network, there is no indication as to whether any of these providers are open panel or closed panel. That is, whether they're accepting patients or not for any of the primary care providers listed on their network. In addition, there was no survey submitted that would help the department and the public analyze whether Anthem is offering a level of service on its narrow network that meets members' needs. Now, this is important. And it's been talked about here today that, well, this is a new plan and there weren't any people in the network, so we couldn't really determine, who would have access or not. But bear in mind, Anthem has been insuring the people of New Hampshire for 10 years now. They've got data about who has access and who doesn't have access, and they're required on an annual basis to tweak their network adequacy in their normal network to determine whether or not there are areas of the state where they need to add providers, whether or not there's adequacy on a broad basis. You would think that under the circumstances, they could have provided some of that data to say, hey, look, we're going to take away a hospital and its service providers that's serving a major portion of the state. What's going to be the effect of that omission on patient care? The data was there and it was never submitted. Next slide, please. The next standard that's been talked about is patient waiting times. Now, the standard refers to what are called the NCQA requirements. That's the National Council on Quality Assurance. It's a private entity, and it evaluates healthcare facilities, healthcare networks, and insurance products for their quality, broadly speaking. And it sets different standards. And I can see why the department referred to these standards, because the department might not have the ability to revisit these standards on an annual basis, and they're intended to evolve over time, whereas that's the NCQA's mission. And so referring to that outside standard isn't a bad idea. What the NCQA requires for primary care providers is about 30 days from first calling for an appointment to getting an appointment. But I note that for the ACA, excuse me, the state of Vermont is going with a 14-day standard for that very same thing. And here in New Hampshire, for managed Medicaid, which is the subject of much discussion these days, the requirement is also 14 days. So if you're on Medicaid, you're supposed to be able to contact a provider within 14 days. But if you're getting your insurance through private Anthem, they're only required to adhere to a 30-day standard. And so I would urge, and I'm going to urge at the end of my conclusion, that we think about whether that's the appropriate standard. But whatever the standard is, Anthem submitted no information at all about waiting times to the department for consideration as to whether this network was adequate. And that is a factor in determining network adequacy. And again, this isn't a matter of this being a new program or plan. It's a new product, but Anthem has been in this market for a long time. They insure tens of thousands of people, if not more, in this state. I'm sure the data is there if they wanted to use it to demonstrate what the effect would be on waiting times of taking away providers from different areas of the state. And that's exactly what's happening. As the president of Anthem testified in front of the Senate last fall, what they're trying to do is lower the number of providers to increase the volume to those providers so that those providers are willing to accept their lower reimbursement rates, right? But when you put more water through a smaller pipe, you're going to get a lot more pressure in the system. And that's precisely, I suspect, what's happening here. But there's no way to tell because Anthem did not submit the necessary data for the department to analyze that question. As a matter of pure logic, though, if you take away providers from an existing network, you can guarantee, I would think, that you're going to have increased waiting times and decreased access. And this is something that's been of concern even for the in-network providers. Dartmouth-Hitchcock's president spoke last fall when the details of the narrow network were publicized, expressing doubts about whether Hitchcock could handle the increase in volume over its current patient accessibility rate. And if Dartmouth is going to have a problem, we need to look at what the access issues are for the other hospitals that are in network. Anthem also submitted a host of geographic information, and I'm going to talk about that in a minute. Turning to slide 9, the next one, please. Go ahead. Yep. Now, all of this information that I'm talking about was supposed to be aggregated into one easy place, into a report, the Network Adequacy Report, where all the questions would be asked, the standards stated, the answers provided and documented. This is for the department to conduct its analysis. It's for the public to conduct its analysis, for people to understand whether this network is network adequate by reference to one easy document. To slide 10, please, the next one. While Anthem did submit a whole raft of different papers and maps and provider lists and so forth, there was no comprehensive adequacy report. If we reviewed everything that we submitted, that Anthem submitted, which we did after we made a public records request of the department, and we've been told that we've gotten everything that Anthem submitted in terms of network adequacy. Even looking at what they submitted, it doesn't look like they met the requirements of that network adequacy report that is required under that regulation. You'll also note under C that they're required to post this on their website. Could you flip to the next slide, please, slide 11? I'm showing you here screen grabs that I did the other day. On the left is what you get when you ask Anthem, when you click on, here's our network adequacy report on their website. Anthem requires you to submit your name and your contact information and your address, and presumably they'll mail you a copy of the report. On the right is what Aetna does. Aetna states all the regulations on the left-hand side, all the stuff that I talked about, 15 miles, accessibility, waiting times, number of providers, accepting patients and not. It's all right there. And then it states next to it what the standards are and how they've been met by Aetna. If you open one of those PDFs, the data is there and the documentation is there. Included in Aetna's analysis is also, as required by this report, a lengthy review of how Aetna on an annual basis is supposed to analyze the network and tweak it as necessary to ensure its adequacy. There's also an analysis of how Aetna plans to provide services in rural areas as required by the regulations. And bear in mind, Aetna is an open network. It's not trying to do a narrow network. Slide 13, please. So Anthem's information in that regard should have been more properly scrutinized. Had they actually measured the information that Anthem submitted against the requirements of this network adequacy report, we would find that many of these issues haven't been met. It's hard to read these, but basically it says you need to submit maps showing the residential location of covered persons in New Hampshire. Again, the argument is that, hey, we don't have anybody in the network yet, so we can't tell where they live. But again, Anthem has the data. It's out there. They could have submitted a current accessibility analysis for where their patients live now and extrapolated from that where these are smart folks over there, and they have big computers. They could have done this. There's no analysis as required on a county-by-county basis of who is accepting and who is not accepting patients. There are tables that Anthem submitted showing the percentage of proposed insured who would meet the access standards, but it's impossible for me to understand how they arrived at those numbers if we don't know where people live and no survey was conducted asking them how long they're currently waiting to see their physicians. So at best, the submission was incomplete. And there's no analysis toward the bottom of Anthem's process for meeting network adequacy on an ongoing basis, and no plan for how Anthem intends to provide access in rural and underserved areas. Next slide, please. So that's my analysis. And then the next slide, please. So to recap, there's no complete network adequacy report, there was no consumer survey, and there was no analysis of waiting times. Okay, next. And go ahead to the next one. So here's the last regulation in 2701, and my colleague Neil Castaldo is going to address this a little bit later. But basically, the regulations require that these standards are met across the board and that documentation be submitted. That the documentation is inadequate is, in my view, and it's an absolute fact. Attorney Patterson talked about objective standards having been met, and they just haven't been met in this case. That the network appears to be equally substantively inadequate seems also quite apparent to me. The Commissioner has the power and the duty to remedy this situation today. So I've talked a little bit about the process. The end result of this process was a network that, as Mr. Wright stated, omitted some of the poorest areas of the state. If you could flip to the next slide, please. I'm showing here the geo-access map submitted by Anthem as part of its submission for primary care providers. And the circle down in the bottom right is the circle encompassing the northern Stratford County area that's generally speaking served by Frisbee Memorial Hospital. You can see down at sort of about 530 on that circle, there's a dot with a provider there. That's not Frisbee, obviously. and it's not clear from the map whether it's in Rochester or Somersworth, but we believe, based upon a cross-examination of the providers that were listed in Anthem's network, that this is the Goodwin Health Office in either Somersworth or Rochester. And we actually gave them a ring to see when they would be accepting a new patient just coming onto the network, and they said they were booking into May. So we definitely agree with Mr. Brannon that a PCP relationship is not very worthwhile if you have to wait 4 or 5 or 6 months to get an appointment, and that appears to be what's going on here, especially for those folks who live up in the northern part of the county who would naturally go to the Rochester area for their primary care services. Next slide, please. There's another, next one. There's another hole in northern Sullivan County. Next slide. There's another one in northwestern Grafton County in the Woodsville area. Next slide, please. And then Coas, obviously. And then finally, last slide, in the Kentucky Valley area that's served by Peterborough and the Monadnock Hospital, and we heard from them a little bit earlier today. So where are the network providers? Next slide. That's the network, and if you look at those blue circles, you think, well, that's not bad, right? But if you look at the gaps in that network, it becomes more problematic. So slide 24, please. Focusing on the gaps, again, these are some of the poorer areas of New Hampshire. So Anthem's network left substantial pockets of New Hampshire out in the cold, and they just happen to be some of the least well-off areas in the state. So how did Anthem end up selecting these facilities? It's impossible for anybody to sort of look into the black box, but we were trying to figure this out, so we tried to do some of our own analysis. Again, you'd think that when there's only a single insurance company on the exchange, the department would ensure that the insurer began the construction of its network, which is an incredibly complicated task, but it began construction of that network with adequacy as the prime directive, given the purpose of the ACA and the requirement that everybody participate. But it just doesn't look like adequacy was first and foremost on the minds of Anthem in this case. Next slide, please. It's probably tough to read this letter, but basically this is the cover letter that went in with Anthem's initial submission in May 31st of 2013. And Anthem candidly describes some network deficiencies in the course of this letter. It says that there are some deficiencies in Carroll, Coas, and Grafton County, identifying neurology, otolaryngology, and urology as potential gaps in the network. The next month, so over the course of a month, Anthem did some more work on its network, and it submitted an update to its proposal. Next slide, please. In this cover letter, which was June 24th, 2013, it says, we're adding Exeter Hospital, Lakes Region General, and Franklin Regional Hospital, and their related primary care physicians and specialty care physicians. And as a consequence, there are no longer deficiencies in the specialties of neurology and otolaryngology in Carroll County. Slide 27, please, the next one. And I was struck by this because you've got Carroll County up there, and they added Exeter Hospital to address a network deficiency in Carroll County. Now, I don't know what drove that decision, but it doesn't look to me like network adequacy. The next slide, please. This is Coas County, and this was the original proposal for Coas. That's Weeks Memorial Hospital in Lancaster. You would think that if you had identified deficiencies in Coas and Grafton counties, that you would have added hospitals in Coas and Grafton counties to address those deficiencies. Next slide, please. And indeed, there are facilities there that could have provided that kind of service. You had Androscoggin Valley and you had Littleton Hospital. But as we all know, those hospitals were not added to the network. Anthem believed the network to be adequate without those hospitals in it twice. In fact, those hospitals were finally only added to the network after Anthem disclosed the nature of the network, and it was subjected to substantial criticism from the public. But if Anthem knew that the network was inadequate in June, I have to ask why they didn't add them in at that time. And I think the answer is because network adequacy was not Anthem's primary consideration in coming up with this network. Anthem has also described, and the department has nicely described the balance between cost and adequacy that we all have to strike if we are going to have a manageable healthcare system. And Anthem's public statements, again, definitely frame their network decisions in terms of cost. They say that by having fewer providers, they can drive the higher volume and they can get the better rates because they have the higher volume. But that doesn't explain why Anthem, next slide please, included both Manchester hospitals in its network. And they're only 3 miles apart. Presumably, if the rationale that was applied to Frisbee and Wentworth Douglas were applied in this case, you would have had one and not the other in the network. So I don't believe cost was a factor given that. And that also doesn't explain what happened in Stratford County. Next slide, please. We have here Rochester and Dover, the homes of Frisbee and Wentworth Douglas, Frisbee being obviously towards the top of this. As we've all heard, Frisbee was ready, willing, and able, and is today ready, willing, and able to provide services in its service area at a cost that was comparable to or competitive or the same as the cost that was advanced to Wentworth Douglas. Frisbee, generally speaking, costs less or the same as most other providers. And I was just looking at a Harvard Pilgrim pamphlet today that said that Frisbee is one of two tier 1 providers analyzed by Harvard Pilgrim in the state, which means the best combination of quality of care and cost of care, one of 2 providers. And they were omitted from the network and never even approached by Anthem with the request as to whether they would want to participate or not. So from my perspective, cost wouldn't be the issue. Anthem and its consumers would get the same prices from Frisbee that they get from Wentworth Douglas. Slide 32, please. So these collective omissions have left some of the poorest areas in the state out of the network. As Mr. Brannon was said, we have to think about this in terms of access to services. The folks in these areas, as has been testified to and as is well known in the public health community, face enormous practical challenges in accessing services that under the ACA now, they are required to pay for. So their practical exclusion from this network strikes me just as it struck Mr. Wright. And to illustrate what I mean in detail, I just want to talk about the specifics of Stratford County. Slide 33, please. Here's a map that's produced by the Department of Health and Human Services here in the state of New Hampshire, and I've blown up the portion to the bottom right where the county of Stratford is divided up into 2 health service areas or 2 hospital service areas. The upper one, obviously, Rochester, served by Frisbee. The lower one, Dover, served by Wentworth Douglas. This is how the state already looks at these 2 regions. Slide 34, please. It's probably hard to read, but the upper part are the Rochester area towns. They include Rochester, Stratford, Farmington, Milton, New Durham, and Middleton. And the Dover area includes Dover, Somersworth, Barrington, Lee, Durham, Madbury, and Rollinsford. Next slide, please. In the Rochester service area, the household income for a 4-person family average is $69,800 per year. Next slide, please. And in Dover, the Dover area, it's about $87,000 a year. That's a 25% differential in annual income per household between the 2 service areas in the state. And if you look at the unemployment levels, the unemployment is about 1.5 points higher in the Rochester service area as opposed to the Dover service area. And as, again, has been addressed already today, studies after studies have shown that when you have higher rates of unemployment and lower income levels, you get less insurance coverage, you have worse healthcare conditions and worse healthcare outcomes, and more difficulty in accessing services across the board, even if you're insured. Slide 37, please, the next one. And this CHIP report shows the percentage of kids in each service area and what they have for insurance coverage. On the right is a column with the number of commercially insured. And the next two columns to the left are those kids who are insured by the Healthy Kids program. There are two in New Hampshire, and it's essentially a Medicaid and a branch of Medicaid. And these numbers show that these statistical assumptions you make about less well-off areas certainly apply in this case. Slide 38, please. In the less well-off Rochester area, only 50% of kids are covered by commercial insurance, as opposed to 65% in the Dover hospital area. That means that their parents have coverage, whether it's individual coverage or employer-based coverage, and that the balance of people are either getting their insurance through the government, through Medicaid, or don't have insurance at all. And again, up till now, even today, most adults aren't eligible for Medicaid. So those kids who are getting their insurance from Medicaid come from families that do not have access to commercial insurance and probably aren't insured as adults. These are the patients that Obamacare was intended to address. Obamacare is the mechanism by which these people would acquire health insurance. That is the population that Obamacare wanted to reach. Slide 39, please. Now, on the right is Stratford County with the towns in question detailed on it. And you can see a 15-mile arc, which is approximate arc of the primary care network requirements. Now, I'm using that as a proxy because we're talking about Wentworth Douglas, the facility here, but we needed some basis for analyzing this. And we saw that the closest primary care provider was looking at waiting times out to 4 or 5 months. So again, beyond that arc are the people most likely to have poor health conditions, most likely to have difficulty in accessing care. Statistically speaking, they're least likely to be insured, and those are the people that are now going to be swamping providers in the Dover area as they become insured. Now for Anthem, these individuals with chronic health problems who previously haven't had insurance are the people most likely to be the most burdensome economically. And they are the furthest from the health care that they're going to end up needing and using. And I want to repeat that point, and Mr. Wright made it earlier. The patients that pose the greatest financial cost to Anthem are those that, through the creation of this network, are placed the furthest from the services that they have access to under the law. Since preventive care was a cornerstone of the ACA, having those patients travel that far does not seem consistent with its reasonable access requirements. Next slide, please. Similar dynamics are at play in Coos County. That's the 15-mile arc around Lancaster's hospital. Slide 41, please. Sullivan County and Claremont. Those are the regional hospitals that are in network. And finally, slide 42, Woodsville and Littleton to the right and DHMC down to the bottom left. So what can be done? Slide 43, please. First, the department must require that Anthem meet the stated requirements of the department's network adequacy standards. That means, at a minimum, slide 44, please, submission of a comprehensive network adequacy report. Slide 45, please, the next one. Submission of consumer surveys for the state of New Hampshire to assess accessibility for primary and specialty care providers. And third, submission of a waiting time analysis that ensures that patients seeking primary care will not wait longer than the 30-day NCQA standard, but ideally the 14-day standard enjoyed by our friends in Vermont and by Medicaid patients. Next slide, please. To remedy the problem in Stratford County, and my colleague is going to speak about this, Mr. Castaldo, the department can and must order Anthem to negotiate in good faith with Frisbee to address the coverage gap in the narrow network. Slide 48. The department should revisit its network adequacy standards, and it's heartening to see that they intend to do so. It should harmonize its rules with DHHS at a minimum, requiring a 14-day window for primary care access. And fourth, the next slide, please. The department should support what's known as any willing provider legislation. This is legislation that Frisbee Memorial Hospital supports, and the essence of it is that if you are a provider willing to provide the services at the cost that the health insurance company wants to pay you, then it has to take you into the network. That should be the law here in New Hampshire. Any willing provider legislation is a pressure valve, and it would remedy the gaps in coverage in slide 49, please. And just kind of toggle through them in each of the underserved areas that I talked about earlier. Next one. So finally, and again, this has been addressed earlier and I restate now, it's essential that going forward, the process of approving health plans for the ACA has to be transparent and public, that there be publication of all network adequacy materials, that there be a comment period for written submissions, public hearings, and there's legislation pending right now to compel some of this, and it's heartening to see that the department is trying to get ahead of that legislation, and I urge them to do so in a complete way. I've concluded my portion. I'd like to introduce Al Felgar, CEO of Frisbee Hospital, to speak for a couple minutes.
Good afternoon. Let me read you a letter, it's short, that I wrote to Jim Roche, who's the president of the BIA, which is a very powerful and important organization representing many, many companies in this state. He had written an editorial in New Hampshire Business Review supporting Anthem's implementation of the narrow network. I, of course, object, and I wrote the following. Thank you for visiting with me last week. Here are my concerns and thoughts regarding the rollout of the ACA. Number one, I agree that healthcare costs are very high. Changes must occur. Constructive change that would address costs can only happen when all parties, employers, insurance companies, providers, patients, and the government work together to effect change. Three, the establishment of limited or narrow provider networks, pathway network, in an arbitrary manner with no public discussion is the wrong way to do this. The patient-doctor relationship has been severed. Patients will be required to find a new doctor and drive further for care, in some cases 25 more miles in our northern service area. And 9 hospitals are not permitted to participate in the ACA. In our state, almost every hospital employs the bulk of its doctors. In our case, 80. Excluding a hospital means excluding its employed doctors. Across the state, the total is many hundreds. Our medical staff and others in the state do not understand why, after years of complying with increasing state and federal regulations to improve quality, reduce unnecessary admissions, they were rejected by Anthem, the state of New Hampshire, and the federal government. Our hospital is a lower-cost hospital and one that performs at a high level of quality. Please see the attached documentation, which I sent him. Despite this, we were never given a chance to negotiate a deal with Anthem. If Anthem is really interested in trying to lower costs, why would they ignore us? There are more problems with this rollout. Anthem is now directing more and more of their individual customers, not part of the ACA, to the pathway network. The list of patients thus affected is growing weekly. Why is this a concern? Hospitals earn their surplus, their profit, from payments from commercial insurance such as Anthem, Harvard, etc. All other payments, Medicare, Medicaid, are well below our costs. We survive because of commercial payers. Any dilution of this will over time threaten our viability. In summary, we believe that our patients, hospital, and medical staff have been unfairly treated and are seeking relief from the Department of Insurance of the state of New Hampshire. Every hospital I know gets it regarding the need for change. All I am seeking is an opportunity to be part of the solution. Thank you.
Commissioner Savini, members of the department staff, my name is Neil Castaldo,
And I'm sure for all of those who are hungry, you'll be happy to hear that I'm the last planned presenter for Frisbee. Since I am the last presenter, I wanted to acknowledge some thank yous for this extraordinary hearing. And the first is a thank you to you, Mr. Commissioner, and members of your staff for having the courage to hold this hearing and hear what the community members of Stratford County and elsewhere around the state think about the narrow network that has been initiated. Also, I want to thank you for telling us that there is a rules effort coming up and that you'll be working with the Legislative Rules Committee and that you'll be looking at adequacy standards. And no doubt some of the testimony that was given to you here will influence greatly what you might conclude. That's the right thing to do, and we're grateful for that. But I don't think your work is done yet, at least not for this year. Before I get to that, I have two other sets of thank yous to give. The first is to Al Felgar, CEO of Frisbee. Al had the courage to say loudly and publicly that the narrow network proposal configuration would disadvantage the patients that Frisbee Hospital cares for. He did it when nobody else was public with that notion. And during the course of this journey, he's convinced members of Congress, he's convinced members of the General Court, both the Senate and the House, he's convinced policymakers, he's had interactions with the media, and he's convinced the public in his community that the right thing to do is to include Frisbee in the narrow network. I think he's done the right thing. And speaking of courage, I want to thank the members of the public who came here to testify. They took time off from their work, their lives, to give you the input that they wish they had been able to give before this decision was announced. There's lots of impactful testimony that you heard today. And I want to compliment you, Commissioner Savini, and your colleagues for listening attentively to the public testimony. Several of you took notes. All of you were really concentrating on what the community members have to say. I could call out any number of people, but let me just give you 3 examples. First, in terms of patients, Margaret McCarthy raised 2 points that I hadn't considered before, and I've been thinking about this for over a month. Number one, she said, in this new configuration, she doesn't have to switch from one doctor to one new doctor. She has to switch from 3 doctors in whom she has confidence into 3 new doctors that she's never met before. This is really an issue. She also said, and this struck me as well, that in her current hospital system, there is a uniform electronic medical record, which costs a lot of money in order to implement among these many doctors, because the savings would be realized in the future, the avoidance of needless tests. And even more importantly than the savings was the increase in the quality of care, because any physician in that system can look at the EMR and instantly know what the full medical history is. Having her start a new relationship with 3 new doctors who do not have access to this electronic medical record doesn't seem to me a cost savings. It seems just the opposite. In terms of the doctors who spoke, I think I have to recognize Dr. James Betty, who was definitely the crowd favorite today. Dr. Betty talked about quality of care and fairness, but he mentioned something that one of your staff expressed interest in, and that is the problem of discontinuity of care, his surgical patients. Now, maybe this discontinuity can be solved in future years during this legislative rules process, but how does that help the patient Dr. Betty talked to in January, who had a procedure that he performed on her and now has to find a brand new doctor who's had no contact with that particular procedure? That's really something that should be solved this year. And lastly, I think the award for irony has to go to Steve Hayden, who told us that the Mainers that he referred to have more physician choice options in New Hampshire than we who live in New Hampshire, these people who live in this room. That can't be right. That's wrong. You know what the people said? They said they don't want to travel. It's too far. Some of them can't afford to take time off of work. Some of them don't want to get on the back of a line to meet a physician that they don't know whether they will like or trust. This is a real significant issue for them, and it's concerning to them, and it should be. I think the people who testified here today deserve our grateful thanks, and I think you should all give yourselves a round of applause for your courage in coming. Okay, so what's the unfinished business? You've heard about the lack of reasonable access, the waiting times, the time off of work, the lack of transportation. These are the real problems. But a theme in what you said today, what I've heard, is that you are concerned about cost. This is a legitimate concern. However, Frisbee, I think, has taken that issue off the table. Frisbee has announced that it will accept Medicare rates if it has an opportunity to negotiate with Anthem. I don't know what rates hospitals are charging Anthem for participation in this network. I don't know. It's not for me to know. It's private, confidential information. But I think you, as being experts in the field of health insurance, should know better than anybody else in the room whether an offer to provide services at Medicare rates is a good deal for Anthem. I think, based on my experience as a healthcare lawyer for over 40 years, is that's a darn good deal. I don't know anything more than that, but I think what Frisbee has done in saying it's going to offer Medicare rates to Frisbee is to say to Anthem, to you, and to the people out there that it's more important to Frisbee to take care of these people than it is to maximize the income it will get from doing that. They should be rewarded for that. But we still have the problem Frisbee isn't in the network. And my point is that you can fix that problem. I had a brief discussion with a staff member before the meeting, somebody whose knowledge and experience I highly respect in the field of insurance. And the person asked me, what are you going to ask Commissioner Savini to do? And I said, I'm going to ask Commissioner Savini to solve the problem today. And he said, the staffer said, well, wait a second. You can't ask Commissioner Savini to do something he doesn't have the power to do. And I agreed with him. I wouldn't ask you to do something you don't have the power to do. But I think you do have the power to solve this problem today. And I'm remembering what James said. James, I'm sorry I didn't get your last name. He's one of the early presenters in the public. He said to you, Mr. Commissioner, find a way to fix this problem. And here's a way. You have the power to issue an order requiring Anthem to negotiate with Frisbee to include its doctors in the network at commercially reasonable rates. My colleague, Jeremy, put up the slide that talked about the regulation. It's Regulation 2701.10. I'm of a different generation than Jeremy. I don't have a slide up here, but I will read it to you. And to the people in the audience, because I don't know that you were aware of this before you came here today. And please, you listen to this, and you conclude for yourself whether this problem can be solved. If the commissioner determines that a health carrier has not contracted with a sufficient number of participating providers to assure that the covered persons have accessible health care in a geographic area, the commissioner shall issue an order requiring the health carrier to institute a corrective action. I don't think the people who testified today think that there are, quote, a sufficient number of participating providers to assure that covered persons will have access to health care services in the communities in which they live. And Mr. Commissioner, if you reach that conclusion, you have the power to order Anthem to negotiate with Frisbee. And on that point, Mr. Felgar has assured me he has time today to do it, if you issue that order today. He has time tomorrow morning, tomorrow afternoon, the rest of the week. He wants to sit down with Anthem for the first time and negotiate for Frisbee's inclusion into the network. Look, I don't think you have an easy job, but I do think this is an opportunity to do the right thing. And I know what you're going to say, and I think I can, in conclusion, anticipate some of the points that I would predict would be of concern to you. Number one, you might say there shouldn't be two hospitals too close together. Well, if that's a concern, I do not understand Manchester. Manchester has two hospitals in the same community. And in that community, there is a very visible and active public bus transportation system that takes patients all over the city and has multiple stops at hospitals and provider offices. So in Manchester, you think that would be the textbook case for one provider, because the public transportation can get people to doctors' offices. Here, there is not that level of public transportation. And in fact, what you've heard are impediments to travel. So I don't think the proximity should be a preventing cause for you to issue that order. And the second is cost. We've talked about Frisbee being willing to take Medicare rates. It doesn't seem to me that with that information, cost should be a factor. But there's a third point too, and you've been coming back to this with our gratitude, by the way, that next year will be different. There might be more providers, there might be better adequacy rules, a number of things might happen next year. But that means you're telling these people to wait. That means you're telling these people for a year that they have to travel to meet doctors they haven't met before and to leave doctors they like and trust. That means you're telling these people that they'll have to do this for a year and then, oh, you can switch back maybe in the second year. Why put them to that trouble? Why not take care of their problems now? They want this problem fixed now. Mr. Commissioner, this is an opportunity for you and the department to do the right thing. On behalf of my client, Frisbee, and more importantly, on the patients it serves, I urge you to do just that. Order Anthem and Frisbee to negotiate, and the sooner the better. Thank you, Mr. Commissioner.
Thank you very much for your opinion, Neil and Al and Jeremy. I really appreciate it. And with that, I will bring the hearing to a close. Thank you.